All right. So this is Patricia. She's a 57-year-old who had her last menstrual period at 51. She had a natural menopause, but at age 50, during perimenopause, she was diagnosed with ER positive, PR positive breast cancer. She had a lumpectomy, radiation, 5 years of tamoxifen, and she finished that tamoxifen therapy about 2 years. And so Patricia is currently cancer-free, and yet she is suffering. She has severe vaginal dryness. Her intercourse, sexual relationships are blunted because intercourse is painful. She's having hot flashes every night. Her sleep is disrupted. She has developed this increased urgency to urinate, and she has tried lubricants. She's tried moisturizers, black cohosh, paroxetine, escitalopram, gabapentin, and she is getting little relief. That's who we're going to talk about today. I have no relevant disclosures. I do some research consulting for Astellas. That's excuse me. Are they seeing presenter mode?
No, if we advance. If I put it in presenter mode. So we're gonna do that. And they see this.
Okay. We're good.
Yeah, we're good. Are you good?
I'm good. Thank you. So no disclosures relevant to this talk. Our objectives today are to talk about how we can safely manage the genitourinary syndrome of menopause in cancer survivors. We will also contextualize the recent removal of the black box warning for hormone therapy that was done by the FDA in October. We are going to individualize to patients and talk about how do we use evidence-based strategies for non-hormonal therapies for vasomotor symptoms, and also apply a shared decision-making framework. So let's talk about what the data tells us as it relates to menopause and survivorship issues. So we know that the induced menopause for survivors, cancer survivors, is much more severe, and it is often undertreated. We see that more than 9 million women worldwide are diagnosed with cancer each year. Breast cancer accounts for about 300,000 of those cases. And at about 6 years post-diagnosis, we see that 90% of breast cancer survivors are reporting vasomotor symptoms. Those are those bothersome hot flashes and night sweats. They are also having sleep disturbances. If we drop down to this box, we see that about 75% of those patients will experience vaginal dryness. That is a reflection of those genitourinary symptoms of menopause. And it's not just about hot flashes and vaginal dryness. About 62% of these individuals will also experience mood swings. And this over here on the right is the rub. Less than a third of these individuals are offered any treatment for their menopausal symptoms. And it's not just about feeling more comfortable, having fewer hot flashes and night sweats. We see that these individuals are more likely to stop endocrine therapy if their symptoms are not managed. So this becomes a condition or a concern of treatment continuation. It is a concern for overall survivability and mortality. So what we know is menopause typically happens on average at age 52. That's the course of natural menopause. Every woman born with ovaries will experience a natural menopause, and yet the experience is not the same. We know that there are many factors that influence the menopause experience. And we will talk a little bit about those today. And what we see is a cancer diagnosis will only amplify that unique experience. This is a framework from the National Institutes of Health Minority and Health Disparities Research, and it is applied to menopause. And I won't walk through every cell, but I do want to point out some of the architecture here. You'll see that we have 5 different domains: the social cultural environment, the built and physical environment, behavioral activities, biological, and the healthcare system. These factors operate on a different degrees of influence, and they include the individual level, interpersonal, community, and societal. And so when you put these factors together, these menopause influencing factors together in cancer survivors, the picture becomes really clear. It helps us to understand that these are potential barriers or facilitators to care. And so if we take a woman like Patricia, a Black woman who has breast cancer, and she's living in a community with limited healthcare access, she doesn't have access to a menopause specialist, we see that many of these women will not be offered care in an equitable way. So it's not just one thing on these slides. We take all of these biological, social, the built and physical environment, the system factors, and they can impact that experience of women across the menopause trajectory. And then you add a cancer diagnosis, and all of these things are amplified. And when we begin to listen to what menopausal patients say, when we listen to what our patients are saying, there are some themes that come forward. We see that menopause is not a universal experience, if you will. It's unique, and there are varying levels of acceptance and outlooks. And I always like to include some of these quotes from patients. And so these are just general thoughts that women have as it relates to menopause. So many women will have this closed, unopen approach. And so if we listen to this Hispanic woman, she says, "My family just didn't talk about such things. I don't know if this had anything to do with culture or not. I still wouldn't think of talking to my mom about this because she never wanted to talk about bodily functions, menstruation, menopause, or anything like that. I thought everyone felt that way." And we see here that many women are minimizing their menopause experiences, where this woman says, as an African American woman, we are always expected to be strong women who aren't supposed to whine about anything. You just take life as it comes and you do what you have to do. If you are having troubles or problems, you just pray them away and you keep going. I don't think that my culture believes that menopause symptoms are something that you would go to the doctor for. And I've always been told to not make a fuss. If I wasn't feeling well, suffer in silence. And don't forget that silence is the golden rule. So these are our patients. So she may be taking tamoxifen, she may be using an aromatase inhibitor. And so the natural instinct is to minimize, not control these symptoms. And so then when it gets really bad, maybe she chooses to be non-compliant with the cancer therapy. And another thing, this uniqueness to menopause, where the patient on the left says, "You know, I think that the symptoms are pretty much the same for everyone, no matter what their ethnic group is or their race is." And that would be the prevailing dominant view that we see, because that is what is reflected in the literature, versus the patient on the right who distinctly calls out that culture is a factor. In my culture, we are used to just getting along. We don't complain about things, natural things like pregnancy, like menopause. We just take things as they come. These are the views that many patients have as they approach menopause. And so here we go back to this Dickensian sort of duality of this being the best of times, it being the worst of times. And that is what we need to, that's what we have to deal with as we approach menopause. So our breast cancer survivors are completely grateful. They are grateful for the oncologic care that they've had, and they are also exhausted. They're tired, they have many sleepless nights, and they are suffering. And both of these things are true. I'm an OBGYN, I'm a trained menopause specialist, and when women come to my office, many of them have said, I've never told my oncologist this because I'm grateful. They don't want to seem ungrateful. And I've had a few say, if I knew that my symptoms were going to be this bad, I would rather have cancer. That's a bold statement. And when I share that with my oncology colleagues, they don't find that believable. But with the sleepless nights, with the impacted quality of care, this is the lived reality for so many patients. And it is important that we appreciate this. So there are more than 300 estrogen receptors throughout the body. And so women may experience symptoms from the crowns of their heads to the soles of their feet. That is the menopause experience. And as I said earlier, the average age of menopause, natural menopause, when those ovaries decline and function, is about 51, 52. It is a gradual process where we have a perimenopause that lasts anywhere from 4 to 10 years as the ovaries begin to decline and function. It is not abrupt. And when we are treating our cancer patients with a cancer diagnosis with radiation, chemotherapy, other endocrine drugs, or in my case, if I am removing those ovaries, then the menopause experience is abrupt. There is no gradual onset. And we see that on average, the median age of that is 44 years. These symptoms are often more severe, they persist longer, and they're being experienced by women who are much younger. Many of these patients will experience a temporary menopause, what we call primary or premature ovarian insufficiency, depending on the level and the kind of treatment. We can see even with a natural menopause that there will be changes across a cardiometabolic continuum where we see an increased risk in cardiovascular disease. We can see a decrease in musculoskeletal function, bone loss, cognitive changes. As I said earlier, a cancer diagnosis, a premature, abrupt induced menopause compounds all of those factors. So I would argue that menopause symptom management isn't just about relieving quality of life issues. It isn't just about comfort. This really is a critical portion of oncologic care because we see that patients who are not treated well are 5 times more likely to stop their treatment. And only 70% of those will stop before completing 5 years of therapy. So let's go back to Patricia. Remember, she's 57. She has been menopausal for 6 years. She's gone through the gamut of treatment and she is cancer-free and she is suffering. She is miserable. The vaginal dryness is so bad. It's impacting her quality of life. She's unable to sleep, and she feels as though she has run out of options as she has tried so many things. So let's talk about how we can help her from the point of the genitourinary syndrome of menopause. This is a constellation of symptoms that impacts the vagina, the vulvar tissue, as well as the bladder. And unlike the hot flashes and night sweats, which on average will last for about 7 years in menopausal women, the genitourinary syndrome of menopause is chronic, it's progressive in the naturally menopausal woman. But these symptoms show up even more severely in induced menopause. And the key takeaway message here is that this is treatable. It can certainly improve, and the treatment, the mainstay of treatment, is going to be estrogen therapy. It is the loss of estrogen from these tissues that decreases vascularity in that area, decreases blood flow, blood supply, and can overall change the architecture of the tissue. GSM treatment is appropriate at any age for any duration and does not require concurrent systemic hormone therapy. Many patients are really concerned, especially our breast cancer patients, about using systemic estrogen therapy. That is not the case here. So on the far left column, we can see our non-hormonal options, which include pelvic floor physical therapy. Many of these patients are experiencing pain or pelvic floor dysfunction. I would say that every one of our patients who is experiencing GSM should have a pelvic floor physical therapy consult. Lubricants are meant to decrease the friction and increase the glide in those that are having vaginal intercourse. We recommend water or silicone-based lubricants because the tissue is already fragile. We want to be careful to select a lubricant that is in a physiologic range that is acceptable, as well that has the appropriate osmolality. We don't want to cause further damage to the tissue. Vaginal moisturizers can be used much like women will use moisturizers on their face and other parts of the body. Having a regimen of a vaginally specified moisturizer can be very helpful to retain moisture to the tissue. And we know that many of the radiation treatments can cause stenosis on top of the loss of estrogen. So we get a shortening of the vagina, a narrowing of the vagina. So using vaginal dilators can be very helpful to maintain patency, the length of the vagina, and keep the vagina open. The other columns reveal hormonally based treatments. As I said earlier, local vaginal estrogen is the mainstay, and that estrogen can be delivered in the form of a cream, a tablet. There is a ring that will sit in the vagina, as well as a suppository. These treatments will bring back the blood flow, help with overall architecture, and reestablish a microbiome that will decrease the risk of urinary tract infections and other vaginal infections here. Because this estrogen, this hormone, is locally delivered, it does not require progestogens to protect the endometrium. And then we have two other options. Prasterone is DHEA. It is converted intracellularly to a weaker form of estrogen. And in this case, particularly, it is delivered on a daily basis, whereas the estrogen over time, we get to a twice weekly maintenance. For patients who are uncomfortable inserting estrogen or one of these products locally to the vagina, ospemifene is a selective estrogen receptor modulator, which can be taken orally. So let's go back to Patricia. Patricia feels much better right now. Her vaginal symptoms are so improved with vaginal estrogen. We're going to monitor her. And when she comes back, she says, I'm still soaking my bed sheets and I'm still not sleeping. And it is that loss of sleep that is killing Patricia's quality of life. So let's talk about how do we manage hot flashes and night sweats in the cancer patient. This shows the general options for vasomotor symptom management. So there are both pharmacologic as well as non-pharmacologic therapies, and we'll walk through those. Top of the list, you will see cognitive behavioral therapy. Cognitive behavioral therapy, a specific type of talk psychotherapy, is focused on building skills and changing the thoughts around menopause. And it has level 1, good, consistent evidence for the relief of hot flashes and night sweats. Clinical hypnosis, as well as weight loss and stellate ganglion blockade, have moderate effects for relief of hot flashes and night sweats. In general, there is no more effective therapy than hormone therapy, specifically specifically estrogen, where we get a upwards to 90% reduction in hot flashes and night sweats. But that's not appropriate for many of our breast cancer patients. It's actually contraindicated. We're going to get into that a little bit more. But as you see here, we have non-pharmacologic options, and we have a whole suite of non-hormonal options, and we'll go through those. So here we have, so we're going to talk a little bit more about the pharmacologic options. Many of you may be familiar that the SSRIs, the SNRIs can be quite helpful for the relief of hot flashes and night sweats. And yet there are a few that we want to stay away from. And in fact, Patricia actually got one of those, paroxetine. Well, if our patients are using tamoxifen to treat their breast cancer, we want to stay away from those SSRIs that have the CYP2D6 interaction, as it may render tamoxifen's metabolite not effective. So we want to avoid those in the case of our tamoxifen patients. And yet the other SSRIs we should think about and use carefully, judiciously. Many of the menopause patients that we see coming in, not only about their hot flashes and night sweats, but many of them are concerned about weight gain. They're concerned about sexual dysfunction. So thinking about the SSRIs and the SNRI class, we need to look at what are the other tolerance or tolerability issues that are there. There are three that emerge that tend to be most accepting in our menopause patients, and that would be desvenlafaxine, bupropion, and vortioxetine. Those are the ones that tend to have the fewer tolerability concerns and side effects, and also avoid that tamoxifen concern. The newer kids on the block are going to be these neurokinin B antagonists. Fezolinetant was approved about 3 years ago, and elezenitant was just approved in October of 2025. What we know about hot flashes and night sweats are that they are likely originating in the hypothalamus, in the brain, and then the suprachiasmatic nuclei. And when those estrogen levels fall, we get overactivity in what we call these candy neurons. And then they trigger our thermoregulatory system where we get overactivity in those candy neurons. These drugs block these receptor, where in the case of fezolinetant, the neurokinin 3 receptor is blocked, and this newest one, elezenitant, blocks not only the neurokinin 3 receptor, but additionally it blocks the neurokinin 1 receptor. So these have really changed the game when it comes to being able to provide effective relief for our patients who are breast cancer survivors who are dealing with these quite severe symptoms. So you'll note that the reduction in symptoms is anywhere from 50 to 70% with these medications. And what is so promising, and some of this data was just recently presented at ASCO here in Chicago just a few weeks ago, is that we're seeing some signals to sleep and mood with elezenitant. Because of the ways in which these drugs are metabolized, specifically fezolinetant is metabolized through the liver, it does require hepatic monitoring, and that is going to be at baseline 1, 2, 6, and 9 months. But with elezenitant, a different pathway, but with this most recent FDA approval, we monitor at 0 and 3 months. And this, I always like to share this in this context, in that the elezenitant has specific trial data in breast cancer survivors. And if you look here, you can see that there is a reduction in symptoms at week 4 that continues on. So this is great data because it is in the population that we're here to talk about today. So this table summarizes what is available for non-hormonal pharmacologic therapy. We have the neurokinin B antagonists, the SSRIs, as well as the SNRIs, and gabapentinoids, specifically gabapentin, can be helpful for the reduction of hot flashes and night sweats. We do have to be thoughtful about how we use gabapentin. At 2,400 milligrams, it is as effective as estrogen, but at 2,400 milligrams, there are significant tolerability and side effects. And then oxybutynin, a drug that we use for overactive bladder, can also be helpful for the reduction of hot flashes and night sweats. So we have options. There is no need for breast cancer patients, breast cancer survivors, to be grinning and bearing it. No woman, whether with or without breast cancer, should have to grin and bear vasomotor symptoms. It's not a matter of comfort. These symptoms are associated with bone health, cardiovascular health, mood health, and productivity. We can do better. Let's go back to Patricia. So you guys prescribed fezolinetant, elezanitant, yeah. And then what happens often? This happens. They're prescribed, they're FDA approved, they're effective, but the insurance doesn't cover it. It's a travesty. So she's still having hot flashes and night sweats, and she's gone through the whole list. The oxybutynin helped her a little bit, but then she had horrible side effects. She had some dry mouth, she had constipation, and she opened up the New York Times and she saw that the FDA removed that black box. And she says, well, can't I use hormone therapy? Everybody's talking about hormone therapy. If you've not been under a rock, you know, everybody's talking about menopause, right? Right. Yeah. Yeah. And everybody's, you know, my office is flooded. Like, can I take hormone therapy? And now our cancer patients are coming in. They've been told you cannot take it, but now, because we took the black box away, many are curious about it. So what do we know about systemic hormone therapy? This is not the local vaginal estrogen. We're talking about systemic hormone therapy in breast cancer patients. So we do have some large systematic reviews and a small RCT which looked at, can we be using hormone therapy in this patient population? Well, the HABITS trial did show an increased recurrence risk. So the hazard ratio was about 2.4, and it was mostly local contralateral disease, not distant disease. And the caveat here is that even in the Women's Health Initiative study, we thought that much of the breast cancer risk came from the progestogen. And in this case, in the HABITS trial, they used norethindrone acetate for that progestogen. So maybe that's the signal there. Maybe it is that specific progestogen which we should not be using. When we look at the Stockholm trial, we did not see a significant effect on new breast cancer risk. So the jury isn't completely supporting this new notion that hormone therapy is for everyone and that we should continue to proceed with caution. We do have a little bit of guidance. So when we are considering hormone therapy and a shared decision-making, individualized, multidiscipline, multi-teamed approach, that's the oncologist, it's the menopause specialist, you've got to load the boat, the primary care physician, and have a conversation about, is systemic hormone therapy appropriate? So perhaps it might be appropriate in those after careful discussion, if there's persistent severe vasomotor symptoms or GSM is unresponsive to non-hormonal options. If we are going to consider systemic hormone therapy, we want to be looking at a transdermal approach. In observational studies, we see fewer VTE risks, so fewer blood clots to the legs, lungs, stroke, or an MI with those transdermal options. And we have to have a collaborative discussion with the patient, with her oncologist. This is very, very nuanced. And there is a recent sort of guidance, but these are not official guidelines. This is from the Coronado group, where they have created this medical hormonal eligibility criteria that is based off of it's akin to what we think about in using combined hormonal contraceptives in medically complicated patients. So using this framework, those that have hormone receptor positive, they're on on endocrine therapy, that's a level 4. We would want to stay away from that, versus those that are hormone receptor negative and DCIS, they've already had a bilateral mastectomy, they have a lower risk stratification. So if we look at use of menopause hormone therapy by different cancer types, when we have an ER positive patient, we generally want to avoid in those patients. And I'm just going to bring in some of these ovarian cancer patients, those that have low grade serous granulosa cell tumors, these that may be hormonally dependent, we would want to avoid. And I will point out here, those BRCA carriers that do not have a personal history of cancer can generally use. Many of those patients are going to have a induced menopause at 30, 40. We're talking about very, very young women who will also bear the consequences of cardiovascular disease, of cognitive decline, of bone health. Those consequences are real and tangible. So in that population in particular, we would consider using hormone replacement to get those young women at physiologic doses. So the others, though, we want to have a shared decision-making conversation. So it's not just about hot flashes and night sweats. It's not just about a uncomfortable vagina or urinary tract. What we see is that there are significant impacts to mood, cognition, and sleep. These are the complaints that patients are really plagued by, where when it comes to mood, we know that the menopause transition in general is a window of vulnerability for mood changes. And remember, those individuals are having this slow 4 to 10 year perimenopause to acclimate to this. And for our patients who undergo an induced menopause, it's sudden and severe. So we see that 62% of breast cancer survivors will report mood swings even at 6 years out. And again, less than 1 in 3 are offered treatment. That estrogen is modulating those neurotransmitters that regulate mood. So the serotonin, the dopamine, and so that abrupt withdrawal can really have an impact. And then here's the duality. They're not just dealing with this hormonal shift. They're also having to deal with a cancer diagnosis, what that means for them, for their family, their overall health. So there's some intersectionality there. Sleep is disrupted for more than 60% of menopausal women. And as I said time and time again, sleep is a magnifier. There's a bi-directional relationship between mood and sleep. If your sleep is not well, your mood tends to not be well. You tend to not mentate and function as well as you would want to be functioning from a cognitive perspective. And we already know that many of our patients are suffering from chemo brain on top of this. So you can see how this cancer diagnosis, this abrupt menopause can compound some of these general menopause symptoms. And yet, when we treat the menopause symptoms, we treat the hot flashes and night sweats, the mood and sleep patterns can also improve. I mentioned earlier that we had good level 1 evidence for cognitive behavioral therapy for relief of hot flashes and night sweats. Well, you know what? This therapy is very effective for mood and sleep as well. Cognitive behavioral therapy, and that I is for insomnia, is the leading treatment for menopause-related sleep disruption and insomnia. And then cognition. I always like to say to my patients, brain fog is real, it's not imaginative. We see that it tends to be transient in a natural menopause. It is not a signal for dementia. So it is important, as I said earlier, thinking about how do we treat these other symptoms so that we can get an improvement in our cognition and so that patients are not walking around as if they are personally failing. We need to validate, normalize, and importantly, treat the symptoms. And just wanted to share a little bit of data as it relates to treating patients that are in this sort of conundrum of how do I get symptom relief. And as I shared earlier, there's such strong signals with elinzanetant for these non-vasomotor symptoms. And this, again, was just presented a few weeks ago at ASCO, where we see improvement across quality of life domains, psychosocial, physical, as well as sexual domains. And that was presented by my colleague, Dr. Claudio Suarez from the Menopause Society. And then as it relates to yoga, the YOGAS trial also demonstrates that there, and I think I have an additional slide, shows some additional benefit. So prescribed, manualized, gentle hatha yoga, and it is, you can see the prescription, it was 2 sessions a week, 4 weeks, 75 minutes per session. We saw an elevation in mood, also decreased fatigue and decreased sleep. So again, patients don't have to suffer. We have behavioral, we have pharmacologic, non-hormonal options, great options to help our patients navigate this journey. And again, want to amplify it. I like to highlight, I'm a gynecologist, and I often say to my trainees, yes, I'm trained to take care of the pelvic organs, but if we're real about it, we're honest and transparent, what kills most of my patients will be cardiovascular disease. That's the leading cause of death. And we're here to talk about cancer today, right? But cardiovascular disease is the leading cause of death for women. So we would be remiss if we didn't recognize the inflection point that menopause causes from a cardiovascular standpoint. So as we think about taking care of survivors, we need to pay attention to their cardiovascular health. And, thinking about these early menopausal patients, so those that go through menopause before the age of 40, we call those premature menopause patients. Those between 40 and 45 are early, and they have a significant risk for cardiovascular disease. When they are able to use hormone replacement therapy and continue that to the average age of 52, we see tremendous mitigation of that risk. So we need to be thoughtful. If they cannot use hormone therapy, then we really need to lean into those behavioral health strategies to improve their cardiovascular risk profile, including a Mediterranean style diet, increasing physical activity, monitoring those lipid levels and cardiovascular risk factors, and avoiding risky substances such as tobacco and alcohol use. And importantly, we need to think about their bone health. When we are disrupting that estrogen milieu and hormonal levels prematurely, we are going to see not only bone loss, we see musculoskeletal loss. So important to get baseline assessments of bone, recommending to our patients calcium and vitamin D, preferably in the diet, and weight-bearing exercise. So I've given a lot of information. Some of it's controversial, and some of it is much more straightforward. And we must think about all of the things that our patient is going through. So these decisions aren't necessarily straightforward. So shared decision-making is critical. And what is shared decision-making? That is listening to your patient. It is understanding her preferences, her values, what matters to her. Because we can have evidence-based therapy, but if that does not resonate with who she is from an individual, social, cultural standpoint, or what's important to her, we write the prescription the patient doesn't get. And then it's also critically important that we deliver the best evidence and we come together as a multidisciplinary unit, as a team to make that decision. And this is a framework that I often use. It is making sure that patients like Patricia knows all of her options, that she has a choice in the matter, that we talk about those options in a complete and thorough way, that we check our biases at the door, and then importantly, asking what is mattering most to you at this point in time? What are your priorities? And then coming together with a decision. And that decision just, treatment doesn't just stop there. Shared decision making is iterative. It's coming back and revisiting. Maybe the priorities have shifted. Maybe a diagnosis has shifted. Maybe her family dynamics have shifted. So figuring out what is mattering most. And central to this is a whole team that helps with this decision making, help to support the number one player here on the team, which is the patient. And all of this requires multidisciplinary care. As I showed that slide with menopause, we have symptoms throughout the body. So we load the boat with all of the relevant practitioners that might include a sex therapist, behavioral health. And I think central to this is the patient navigator so that we can avoid those situations that Patricia faced of being prescribed evidence-based therapy and having prescriptions not be approved because we don't have the navigation services to really tag that prior authorization to make sure those prescriptions are covered. So survivorship care as it relates to menopause is multidisciplinary care. So here is Patricia again, and she felt like she was running out of options, and we used shared decision-making for her. So after going through all of this, after using a team-based approach, she did move on and she is scheduling for follow-up. So that follow-up appointment is the outcome. Again, it is the continued iteration of figuring out how do we best treat her, making sure she understands all of the options. And again, these can be some of the best times because we've extended survivorship. We're getting our patients to the point of thriving. And it is our job here to try to make these the best times right, while we're also minimizing those worst times, those untreated symptoms. So I thank you so much for your time and attention. And if we have time, I'm happy to take any questions.
Can make a comment on discipline intent, just to throw this out there. I've been the prescriber of this agent for quite a while now, since the FDA approval, and I didn't be here, but they were skittish because they don't have an FDA approval in this space, so they don't want to look like they're marketing. That said, they have a specialty pharmacy, so if you're a provider trying to get this drug, it actually works out to be cheaper than the insured price to go through the specialty pharmacy. So there's a workaround there.
Yes.
Because the alternative medicine that we all give, Despen or Baxi, it's actually more expensive.
Yeah.
They're paying for it for the more expensive. Just throwing that out as
yes.
Funds.
I'm glad you raised that. There are ways to get our patients help with these newer effective therapies. It does take time, right? And that's why it is, I think navigation is important. And our patients don't have to suffer, right? We've got really good drugs on the market, and certainly there are many advocacy campaigns going on. And I think about us being here in Illinois, we have had legislation that actually went into effect in January that compels insurers to cover effective drugs. That doesn't mean that many providers have to do diligence to make sure that they are covered, but we can do better for our patients.
Ask another question. There's clearly an awareness gap to getting survivorship care to our patients. Do you have ideas or suggestions for what people, not just academic practices, but practices, how do we get them to a person like you?
Thank you for asking that. And over the course of the years, we've done some research with some of our residents and fellows, and what we have learned from cancer patients is they would appreciate to have co-located care, right? So a menopause provider embedded in their oncology space. And that's not achievable for every institution. It just doesn't make sense. So what I would say is for oncology colleagues, don't have menopause care be an afterthought, right? So some of the things that you can do is just put it on your workflow. So you're going to order, you've got your maybe basic labs that you're going to order, have on your workflow. I am going to send her to a menopause specialist or to someone who has some advanced training and awareness. That needs to occur simultaneously as you are making that diagnosis. Like that has to be a part of the workflow. So we are working to create that awareness, generate that awareness, but have it go upstream, because far too often this conversation doesn't happen until the symptoms have already started. You're so far down the road, or you're overwhelmed with the treatment and going back for chemo or radiation or whatever is on the treatment plan. These symptoms, unmitigated, disrupt the oncologic treatment plan. And I think it is that mind shift that we have.
All right, good afternoon, everyone. Thank you for coming. My name is Alex Bruhl. I'm one of the senior hemonc fellows at UI Health. For the next 50 minutes or so, excuse me, I want to walk through some of the updates in advanced breast cancer that we've seen in the last 6 or so months since the last CME series. A lot of what we're going to see today is from ESMO Breast in May and from ASCO a couple of weeks ago here in Chicago. So let's get started. Just to begin, I used some generative AI tools for making this presentation, Open Evidence, Claude, a little bit of Gemini. All the data, though, I've gone through manually to confirm with what was just presented at the conferences in Europe and here. So any errors are mine, not the models. And I'll be talking about some investigational drugs as well and flag the ones that are pending FDA approval. So just a sort of 5-part structure for today. It's a little chopped up, but hopefully you can read it. I'm going to start by talking about why the field is moving so quickly. And then, of course, the bulk of the talk will be on HR positive space. Touch a little bit about HER2 positive metastatic breast cancer, mainly some emerging evidence in the cross-resistance signals. And then I'll also just discuss a couple of the new first-line therapies approved in the triple negative space as well. And we'll kind of try to tie it all together. So why does this feel a little bit different right now? Right now, biomarkers are not really the tiebreaker. They're the default. They're what we should be testing at second line at the very least for all of our patients in the HR positive space, especially. ESR1, PIK3CA, the PAM axis, HER2 low, PD-L1, BRCA. These are all essential now that we have multiple lines of therapy depending on what we're seeing on these biomarkers. Additionally, ADCs, antibody drug conjugates, are now a feature of every subtype. So T-DXd, sacituzumab, datopotamab, HER3 ADCs, and also, of course, combined with immunotherapy. And we'll be discussing some of the emerging literature on sequencing these and some of the cross-resistances based on the payloads as well. And then third, more from a regulatory perspective, we're seeing a little bit of pushback from the FDA. I think the most clearest example in the last few months is SERENA-6, where ODAC voted against the approval of the regimen back in April, largely on trial design concerns. We have some updated information from ASCO showing some PFS2 data that are now significant and some ctDNA clearance data as well that have come out. And so we'll see in the coming months how that may affect the FDA's decision. All right, so for part two, the HR positive, HER2 negative space, this will be the bulk of the talk and mainly tying over from a lot of updates that we discussed at the Winter CME. So this is, and not just how I see, but how we see in the NCCN guidelines for management of the HR positive space. First line for most patients is going to be an aromatase inhibitor with a CDK4/6 inhibitor, fulvestrant in a couple of cases as well. That's category 1, pretty standard. Slight exception in patients that are progressing within 12 months of finishing their adjuvant AI or who are progressing while on their AI. If they have a PIK3CA mutation, they would qualify for an inavolisib with palbociclib per the INAVO 120 study. But the bulk of today's talk and where a lot of the action today is in the second line setting. It's driven entirely, or for the most part, by looking at the PAM pathway and ESR1 mutational status as well. If you have an ESR1 mutation, you're going to be looking at the SERDs or now a PROTAC, a new mechanism that I'll be discussing in a little bit. If the PI3 kinase pathway is altered, you have a approved option and hopefully maybe another couple of approved options down the line as well. But also for wild types, we have approved agents. Beyond the second line, you're looking at ECs, PARP inhibitors based on BRCA status, other things that are sequenced by biomarker. But again, the bulk of the talk is going to be, and in this part of the talk is going to be on the HR positive space. I think the most important habit that I think a lot of us have picked up on since Emerald back in 2023 was doing these biomarker testings at the sign of progression to help us figure out how we're going to sequence our patients. So as Dr. Hassan actually reviewed at this last CME series back in the winter, I think one of the biggest unmet needs in this space is breaking through the 6-month PFS barrier that we've seen in a lot of studies traditionally, though fortunately we have several new studies that are showing PFS well beyond the 6-month sort of ceiling that we described previously. That's where a lot of the pipeline is also directed. First line works pretty well, right? We're seeing PFS around 2 years, OS north of 5 years at this point from Paloma, Mona Lisa, and Monarch. But about 20% of patients in any of those studies are going to have progression within the first 6 months, and so they're primary endocrine resistant. And for years, the second line monotherapies that we've had have not really been able to break 6 months of PFS once they progress on these first lines of therapy. And so that's where a lot of attention has been appropriately placed as well. As I said, we have Avera, we have EMBER-3, Victoria-1 now, regimens that are beating this 6-month PFS ceiling. And of course, a few other drugs along the pipeline that are promising as well in some phase 1 studies. For example, termocyclib, which is a CDK4/6 degrader. We have a CDK4 selective drug. There's another BTX9341 that's a CDK4/6 selective degrader. PAM inhibitor from Victoria-1, gedatolisib, that I'll talk about in a little bit. But the strategy is by and large the same. We're trying to get past these resistance mechanisms along the pathway. PI3 kinase, AKT, mTOR, CDK2, CDK4, etc. Trying to restore the endocrine sensitivity in these patients. This is sort of the biology behind this ceiling that we've been discussing for a while. I'm not going to go through all of the pathways exhaustively today. I just kind of review where our focus is going to be when I'm talking about some of the agents that have come out. This is most of this image is from a review from Lloyd a couple of years ago. I added the cutoff, but the gedatolisib or gedatolisib, pronounce it how you like. That's unlike alpelisib that was a couple of isoforms of PI3 kinase inhibiting. Gedatolisib is inhibiting 2 isoforms of mTOR and all 4 of the isoforms of the PI3 kinase. But first, from the top, you got the ER axis itself with ESR1 mutations conferring ligand-independent ER signaling. And so the receptor essentially stays on no matter how much you deprive estrogen. That's where we get our oral SERDs, some SERMs, PROTACs, SERANs, SERCAs, a lot of alphabet soup that I'll also describe in a couple of slides as well. But that's the focus of those novel agents. Then we got the receptor tyrosine kinases that are really our targets for a lot of the ADCs, HER2, HER3, TROP2. And then, of course, intracellular signaling, as I discussed with PI3 kinase inhibitors, PAM inhibitors, mTOR inhibitors, and AKT inhibitors, as well with capivasertib. And then, of course, the cell cycle itself with the cyclins, we get our CDK4/6 inhibitors, and then, as I discussed, there's a couple of more selective inhibitors that are coming down the pipeline. How do we sort through these all these wonderful agents that we're seeing come up in second line and beyond? First, we got the oral SERDs, the selective estrogen receptor degraders. We have approval for elacestrant and imlunestrant. I'll be discussing camizestrant in the SERENA-4 and SERENA-6 with attention to SERENA-6, of course. And giredestrant was another one that was also investigated in the first-line metastatic setting that we'll discuss in a few moments. Then we have PROTACs, which stands for the proteolysis targeting chimeras. They're targeted protein degraders, so they initially bind to the estrogen receptor, then they signal intracellular degradation through the proteasome. And that's the first of its kind that was approved, the veptidestrins from the VERITAC-2 study that was approved in the second-line setting for ESR1 mutant patients. We also have novel SERMs coming along that readouts expected next year and beyond through the ELAINE and the OPERA programs as well. I won't be talking about those today, but those are things to keep in mind as we look down the future. All right, so Cabatello 291, just one moment. Right, Cabatello 291. We've known about this data for some time. We got some final readouts at ESMO Breast this year with Hope Rugo. And so in the intention to treat population, we saw that the overall survival benefit was numerically significant, but not statistically significant between the populations. And even in the subgroup of the PIK3CA, KT1, and PTEN altered population, which is about 40% of the overall population in the study. The median OS was 28.5 versus 30.4 with the confidence interval crossing 1. So first, you might say, okay, the overall survival is a negative read, but I think we'd be missing, I think, the bigger picture and why this was approved before we saw these OS data. The OS analysis was a secondary endpoint in the study, and only about 53% powered. There's also a lot of crossover. About 42.5% of the control arm later went on to a PI3 kinase, AKT, or mTOR inhibitor, or their CDK4/6 agents, versus only about 26% in the CAPI arm. And about half of all patients got 3 or more additional agents after they progressed on whichever one they were randomized to in the study. When you have that amount of crossover, it's going to be harder to really see a signal in the OS, which is, I think, what was going on here. And the cleaner the subgroup, especially patients with prior CDK4/6 inhibitor use, is still numerically extended in their overall survival by about 7 months. But again, some of the endpoints that they presented at ESMO Breast are not obscured by this crossover. For example, PFS2 favored CAPI with a hazard ratio of about 0.68, and the type 2 subsequent chemotherapy with a hazard ratio of 0.62. So while we're not curing these patients yet in 2026, we're certainly trying to spread them toxicities of cytotoxic therapies, and I think this is very reassuring in that regard. And again, the original PFS in the altered group was 7.3 months versus 3.1 months in the control arm, with a doubling of their PFS. So I think that's also very promising. It explains a lot why we saw the approval from the PFS data alone. So this doesn't really change much in terms of the indication recommendations, I think, for capivasertib and fulvestrant. But I think, seeing the PFS2 data and the multiple lines of therapy that patients are seeing even after exposure is very promising. I thought this drug, it's a phase 1. I think we have several years before we see any movement here, but I thought it was an interesting readout. So this is on BTX9341. It's a bifunctional molecule. So it's both a CDK4/6 degrader and also inhibits CDK2 in the cell cycle pathway. So instead of sort of sitting at the active site like our CDK4/6 inhibitors and inhibiting that, it also targets for destruction by the proteasome, similar to the PROTAC that I mentioned earlier, veptidestrant. We saw this at ESMO Breast. Some phase 1 data, about 24 patients. All of them had prior CDK4/6 inhibitor with a pretty large plurality getting abemaciclib. About 43% had that in their first-line therapy. We saw a lot of target engagement with the SDK reduction and some of the serum markers for activity. Again, it's a phase 1. We'll see if and what phase 2s come to show, but I think this novel mechanism of action was interesting to point out. Of course, Victoria-1 and the wild type cohort. I'll also talk about the mutant cohort next. We read about this a couple of months ago before ESMO Breast, but that's phase 3 looking at the PAM inhibitor, PI3 kinase, mTOR. Again, all 4 isoforms of the PI3 kinase, unlike alpelisib, and both of the mTOR molecules, unlike everolimus, in combination with fulvestrant, with or without palbociclib. So 3 arms in the second-line setting. All of them were required to have had a prior CDK4/6 inhibitor with a plurality, actually majority, I think, had palbociclib. And so this is kind of a 2-part study. There was a cohort with PIK3CA mutations and wild type patients. The wild type we'll read out a little bit later, so I'll discuss that in the next slide. But what we saw is that in the triplet arm with gedatolisib, fulvestrant, and palbociclib, we see a PFS of 9.3 months, again, breaking through that 6-month threshold that's been historically difficult to break through. We also saw this as well for the doublet arm without any palbociclib, with a PFS of about 7.4 months. The control with just fulvestrant alone, with a PFS of only about 2 months. And so even in the wild type disease without any clear markers of mutations in the PI3 kinase pathway, we're seeing significant improvement in the PFS well beyond the traditional 6 months that we've been seeing before. I think another catch that we've been looking out for is toxicity, both physiologically and in terms of time. About 69% of patients had stomatitis of any kind in the triplet therapy, 57% in the doublet arm. And there were actually 2 treatment-related deaths in the triplet arm. This regimen requires really strict adherence to oral care and mucosal care with oral dexamethasone. But there were not, I don't have the number here, but there were not as many grade 3 stomatitis as we might have expected with, for example, everolimus historically. Additionally, I think this helps validate some of the data that we have about continuing CDK4/6 inhibitors in the second line if it was started in the first line, especially in PI3 kinase mTOR-driven disease. Though in this one, again, they're all wild type. Also, and we'll see more in the second part of the study where we're directly comparing to alpelisib, we're not seeing nearly the same degree of hyperglycemia, and we're not seeing the same grade of hyperglycemia in patients that are receiving the medication. As a disclaimer as well, gedatolisib is a once-weekly infusion for 3 weeks on, 1 week off. So rather than having all the medications taken with pills at home, they are required to come in for their infusion, which is, other than the physiologic toxicity, as I said, with stomatitis, hyperglycemia, neutropenia, and the arm with palbociclib, also requires getting to the clinic, sitting for the infusion, and for oncologists and those in the office, that requires time in the chair as well. This was, I think, in April or May, so we knew that before as breast, and then at ASCO, we had positive top-line results for the PIK3CA mutant cohort of the study as well. So the arms were a little bit different, again, because the standard of care was alpelisib with fulvestrant in PIK3CA mutant patients in the second-line therapy setting, or in the second-line setting, with the other arms being a doublet of gedatolisib weekly with fulvestrant versus gedatolisib with fulvestrant and palbociclib. This was presented as a late-breaking abstract at ASCO, and I think I'm excited to see again what the FDA has to say later this summer, because I think this comparator is pretty meaningful. This is some discussion over whether fulvestrant alone in the PIK3CA wild-type cohort would be what we consider standard of care now, with everolimus and some data from post-Monarch continuing abemaciclib or switching to abemaciclib in the second line after they progress on first-line CDK4/6 inhibitor. But I think it's pretty clear-cut with alpelisib as a second-line therapy for the PIK3CA mutant population. PFS, I think, speaks for itself as a whole. We'll talk about the differences between the 2 arms, but 11.1 or 11.3 months, again, well beyond 6 months ceiling that we've historically seen in the second-line setting for HR-positive metastatic breast cancer. Compared to the standard of care, alpelisib and fulvestrant, that, again, the hazard ratio was 0.51. So we're seeing doubling of this PFS in either of the doublet or the triplet cohorts. What I think is really interesting to me is we're seeing a nearly identical PFS, whether you get the triplet or the doublet. And so that brings to question whether the additional possible toxicity of the palbociclib with neutropenia is worth the squeeze. It's not powered to answer that question of whether doublet versus triplet is better, but certainly brings that question to mind. And as I mentioned, there was in the wild type cohort in the triplet combination, there were 2 treatment-related deaths. So it brings to question how much bang we're getting for continuing palbociclib in this specific indication. Also, as I said before, we got to really compare head-to-head the hyperglycemia rates with alpelisib versus gedatolisib. And in the alpelisib arm, we're seeing about 58% of patients having some degree of hyperglycemia. 14.5% was grade 3 or higher versus only 3% in the doublet or the triplet arm. Diarrhea is most of the same with, sorry, not most of the same. We're seeing significant differences there as well. 15% in the gedatolisib arm versus about 40% in the alpelisib arms as well. So comparable or better efficacy with these combination triplet versus doublet regimens. And I think the toxicity burden is shifting from metabolic more to mucosal. So we're seeing significantly more stomatitis in the gedatolisib arms, but not leading to too many treatment discontinuations because of that, and relatively few grade 3 toxicities or higher. I think, the FDA should rule on this in the next couple of months, but if it is approved, I think it may displace alpelisib for the PIK3CA mutants in second line. Again, you still have the toxicity of time toxicity of patients having to come into the clinic to actually get these infusions for 3 weeks on and 1 week off, versus with alpelisib, while you have a lot more metabolic complications, they're more liberated from the clinic. Of course, still having to come in monthly for their fulvestrant injection, but that's can be orders of magnitude different in terms of the time spent in the clinic. Then we have Serena 6. So this I was very excited to read about. It's a pretty different conceptual strategy from what we've seen previously. We're trying to preemptively escalate patients' regimens based on liquid biopsy alone rather than radiographic evidence of progression. It's a unique design in that sense. And so these are patients that were already on their first-line therapies with an AI or CDK4/6 inhibitor. They're doing okay. We're checking their ctDNA for ESR1 mutations every couple of months. And then at the point of the emergence of the ESR1 mutation, we're randomizing them to either continuing therapy with AI with CDK4/6 inhibitor or switching them to camizestrant, an oral SERD, at the time of ESR1 mutation. Initially, it looks pretty great, right? We see a PFS of 16.8 months. That's outstanding versus 9.2 months, a doubling of the PFS more or less. And it also held across mutational subtypes, PIK3CA, TP53, also KIL mutants as well. And at ASCO, we got some PFS2 updates and some ctDNA clearance data as well, with PFS2 now statistically significant at 25.7 months versus 19.1 months, and it has a ratio of 0.63. And also the chemo ADC survival beyond that was also longer in the camizestrant arm. We're also seeing significant clearance of ctDNA with 99% median reduction within 8 weeks versus with 51% of patients clearing their ctDNA of residual cancer entirely. The question then is, why did ODAC vote against recommending the regimen back in April? And it goes to the design of the study itself. So again, remember, patients are on an AI with CDK4/6 inhibitor, and then when they develop an ESR1 mutation, are randomized to either continue their AI and CDK4/6 inhibitor or switch to the new agent. What it doesn't answer is at the time of radiographic progression for patients that were on the AI and CDK4/6 inhibitor, they were not allowed to cross over to camizestrant. So we're seeing that there's a benefit to switch to camizestrant at the time of ESR1 mutation. What we're not seeing is that better than switching to camizestrant at the time of radiographic progression? And that was the crux of their argument. I think some of the data that was presented at ASCO, like the PFS2, as well as the ctDNA clearance, I think is very helpful. And I think, again, when we're trying to predict how these patients are going to go in the future, and sequencing treatments is very helpful. We'll see if it ultimately is able to convince the FDA. Though notably, it's already has a positive opinion with some of the EU regulatory bodies, and is actually this schema is approved in Saudi Arabia and the UAE for this use. So they did extend their deadline for the FDA decision. So I'm not sure exactly when that will be discussed, but I think these updates from ASCO are reassuring, and we'll have to see what the folks over at the FDA have to say. Moving on to persevERA. So to counterbalance a lot of the positive studies that I discussed, we do have a negative first-line study. This was looking at giredestrant, an oral SERD with palbociclib versus letrozole with palbociclib in the first-line setting, with the primary endpoint being PFS. And in the giredestrant arm, PFS about 33.1 months versus 28.2 months. And the p-value, of course, being greater than 0.05. The OS is relatively flat, and hazard ratio is about 1, with basically identical response rates between the groups. Wonder, why are we seeing this miss? I don't know if we have conclusive reasons why, but I think something to look at is the PFSs themselves. I mean, that even on the control arm with AI-CDK4/6 inhibitor, 28, 30 months is already on the very high end of what we'd expect for PFS in first-line patients anyway. So it could have been that the patient or the patient population selected for the study happened to be very endocrine sensitive, and we're not seeing much discrimination between the two arms because they happen to have been relatively endocrine sensitive. I think there'll be a lot of post-hoc analyses to try to understand what else is going on here, but I think this, is not changing our first-line therapies right now. SERDs are going to continue to be preserved, no pun intended, for the second-line setting, and we'll see if at some point the SERDs make their way into first-line, but not yet ready for prime time. And so this is what our HR positive, HER2 negative paradigm for really first and second line is looking today. The approved recommendations are essentially the same as the beginning of this presentation. What we'll be looking out for in the next few months is what the FDA has to say about the Victoria-1 regimen, both in the wild type cohort as another option in wild type patients that would be competing with fulvestrant and everolimus or fulvestrant with abemaciclib. Cross trial comparisons. They're going to be tough because the control arm in Victoria-1 was fulvestrant alone in the wild type arm, as well as seeing whether we get another approval in the PIK3CA mutant space with a similar combination as well. Again, having to weigh the costs and benefits both of the physiologic toxicities of the Victoria-1 regimen and the time toxicity as well, having to come into clinic. But I think it's very reassuring to have multiple options in that space as opposed to one out of necessity. I think another thing which we've known for the last 3 or so years is that it's very important for us to be testing, especially at progression on first-line therapy, because that dictates what available options we have going forward, whether they're PIK3CA mutant, ESR1 mutant, or wild type for both. The next sequencing of their treatments is very heavily dependent on that testing. For ESR1, you can get away with ctDNA and a blood test. For PI3 kinase, AKT1, PTEN mutations, it can be a little bit less sensitive with liquid biopsy. So if you're able to get a solid biopsy, which is recommended, you're also going to be, of course, staining for PD-L1 and HER2 status as well as they continue to progress. So that's it for the HR positive, HER2 negative space. Now I'll be discussing some of the updates in the HER2 positive metastatic breast cancer space. So again, the preferred map from NCCN guidelines, THP remains category 1 recommended for first-line therapy in HER2 positive metastatic breast cancer. We got that from the Cleopatra study. It's tried and true. And this new entry that we saw about 6 months ago was T-DXd with pertuzumab from the DB09 study that was approved back in December of last year. So I want to spend a little bit of time talking about what the implications have been over the last few months and what we might be considering when deciding between these two regimens. The NCCN has listed the DB09 T-DXd with pertuzumab regimen as other recommended and has preserved THP as category 1, predominantly because we don't really know what to do after DB09, though, again, we'll talk about that in the next slide. But their concern is really with sequencing and how we continue to offer patients therapies beyond a DB09-like regimen. Second line, again, if they didn't get T-DXd in the first line, still very standard. I think all paths at some point or another are converging on T-DXd. T-DM1 if they didn't receive it earlier, tucatinib-based regimens as well if they hadn't received either of the ADCs before. And again, with brain mets, there are promising data with T-DXd, though in guidelines, one of the HER2 climb regimens is going to be on your plate at some point. So going to DB09, again, we're comparing the tried and true Cleopatra THP versus T-DXd and pertuzumab. And you look at the PFS, like, wow, when have I seen a 40.7 month or beyond a couple of year PFS, median PFS in this space? You think that's a slam dunk? Why aren't we switching all of our patients over to T-DXd and pertuzumab? We have 44% reduction in the risk of progression, response rates higher than 85%, duration of response of years, 39 months. Safety signals consistent with what we already knew about TDXD, and it was approved by the FDA for this indication back in December. But again, the NCCN has kept THP as the preferred regimen in this space. Again, DB09 did not include any crossover. So we don't know how patients do on a Cleopatra-like regimen once they progress on TDXD with pertuzumab. And we don't have yet a lot of insight into what is the best sequencing if and when patients do progress on TDXD with pertuzumab. We know also that TDXD is phenomenal in the second line and beyond setting. We know that from DB03 and the other Destiny Breast studies. And generally speaking, I think THP can be better tolerated than TDXD, especially when given over that period of time. ILD with TDXD still remains a significant risk that we have to be making sure we have institutional guidelines and recommendations for, and that we're catching it while it's still a grade 1 so that we can preserve the treatment regimen. Once it becomes symptomatic and a grade 2 or higher, we have to permanently discontinue this otherwise very effective treatment. So this slide is kind of for everyone on the care team, what we'll be looking out for, things that that I might consider in offering a DB09 like regimen up front. So again, DB09 has excluded active and symptomatic or untreated CNS disease. That's not unsurprising. We see that in most studies, but we also know from other studies that TDXD is able to breach the blood-brain barrier much more effectively than our other ADCs and other regimens. That question wasn't explicitly asked here in DB09, but it does, at least for me, beg the question of whether or not they had CNS disease to begin with. Is that going to be more or less beneficial than THP? And if they don't have frank CNS disease, is it going to limit the ability for the cancer to treat the CNS as a reservoir for later active disease? I think where I think hardest about it in patients who have large volume disease, who have rapidly progressive disease, high burden of visceral disease, certainly, where we're going to get really fast response rates very quickly to get disease under control and to get the patient feeling better, and to be also inducing a deep control of the disease as well. ILD, I'll just briefly mention here. I know we're all aware of it, but it is real and significant. About 12% of all grade ILD in patients getting TDXD, 3.7% of patients with grade 3 or higher. And as I said, if we are able to catch it with screening or surveillance CT chest, and treat it and hold TDXD before it becomes symptomatic, we can at least have a discussion with the patient and extend the ability to use the agent for longer. But once it becomes symptomatic, we need to permanently discontinue it and, of course, start steroids and follow our institution's protocols. But really taking any little cough, any little disturbance of the patient quite seriously to ensure that they do not progress to life-threatening ILD or toxicities. Other toxicity, of course, that we manage very closely would be GI toxicity with TDXD, which we're seeing, I think, much more pronounced in TDXD and pertuzumab versus the Cleopatra regimen. Again, in the HER2 positive space, in this ADC space, there were a couple of studies that came out over ESMO, 2 negative studies that are really trying to answer or at least point out what signals we might be able to see in sequencing some of these ADCs. Most of these ADCs contain a topo-1 payload. A lot of them are deruxtecan. We also have govitecan with sacituzumab, and they have similar targets, but is the tumor going to remain sensitive to one over the other if they've been exposed to it, or is there going to be an issue of the target of the antibody conferring resistance to the drug? And so this was Satine there were 2 studies that I wanted to mention here. One is Satine, and one is the HER3 DXD Part Z that was mentioned at ESMO. We're seeing, single-digit response rates in patients who had previously received an ADC with a topo-1 payload, both in a novel target with a similar DXD payload, as well as in the Satine study as well. So I think the takeaway is that I know in whether it's TDXD or sacituzumab govitecan or datopotamab deruxtecan or HER3 HER3 deruxtecan ADCs, all these are containing a topo1 payload. And so whether or not you switch the antibody target HER2, HER3, TROP2, the payload remaining the same, I think I would be surprised if we're seeing significant response rates. Again, these are small studies, but that we're seeing, one patient and their best response being partial response is at least brings me concern about sequencing these topo1 payload containing agents. And then moving on to the triple negative space, where we had a couple of new first line approved agents. So prior to the last 6 months or so, our landscape more or less looked like patients having PD-L1 positive could get Pembro with chemotherapy. That's from KEYNOTE-355. And then in PD-L1 negative, we essentially had chemotherapy. And BRCA mutants also been getting a PARP inhibitor at some point. And approved second-line agents were sacituzumab govitecan, most recently datopotamab deruxtecan, and then, of course, chemotherapy. We now have first-line approvals for these agents, though. So ASCENT-04, KEYNOTE-D19 in the PD-L1 positive space, and then TROPION-Breast2 and ASCENT-03 looking at datopotamab deruxtecan and sacituzumab deruxtecan in the IO-ineligible patient populations. So this is kind of what our algorithm looks like now. The first 3 line buckets, we got PD-L1 of CPS 10 or higher, regardless of their germline BRCA status. The now preferred first line is sacituzumab govitecan with pembrolizumab. We got that from ASCENT-04 that I'll go over in the next couple of slides. And then chemotherapy plus pembrolizumab, which we had previously from KEYNOTE-355. But at least we have a non-directly cytotoxic agent now approved in the first line with immunotherapy. In patients who are IO ineligible or CPS less than 10, with a BRCA mutation again in the second line, we're talking about PARP inhibitors from Olympiad and BRCA as well. And then in the IO ineligible, we have approvals for both datopotamab deruxtecan and sacituzumab govitecan from ASCENT-03 and TROPION-Breast2 respectively. At the bottom of the slide, against I think something to take in mind from what we're learning about sequencing ADCs is once you get one kind of topo1 payload, I wouldn't expect much return on your investment on the second line payload, but these are relatively small studies. I would just take our expectations maybe with a grain of salt there. So ASCENT-04 or KEYNOTE-D19 looking at Pembro in the first line with sacituzumab govitecan and metastatic triple negative breast cancer. And these are, in first line setting untreated patients. Median PFS is about 11 months versus 7.8 months with a hazard ratio of about 0.65, 35% reduction in their progression risk with a median duration of about 16.5 months compared to 9.2 months in the control arm. OS is still immature at this point, but I think only 26% of events have been reported, but trending favorably. Safety, no new surprises with the checkpoint inhibitors or with sacituzumab govitecan. We have grade 3 plus neutropenia, about 43% of patients. Basically about the same as in the chemo arm with 45% of patients. Having some degree of neutropenia, grade 3 diarrhea was about 10% in the SASI with Pembro arm. IRAEs were at or around 2% in the Pembro sacituzumab arm, and the discontinuation rate was only about 12% in the ADC with IO arm versus about 31% in the chemotherapy arm. So a bit better tolerated than the chemotherapy with pembrolizumab. So now this has led to the approval of sacituzumab govitecan with pembrolizumab in the first line setting in CPS or in PD-L1 positive patients with metastatic triple negative breast cancer. And then in the IO ineligible are space in patients who have a PD-L1 of less than 10. We now have approval for datopotamab deruxtecan from the TROPION-Breast02 study comparing Dato-DXd versus chemotherapy. And we're seeing median PFS similar to what we saw in the combo with SASI and pembrolizumab, 10.8 months versus 5.6 months with chemotherapy alone. But we do see OS benefit here, about 23.7 months versus 18.7 months, and is currently under this is currently under FDA priority review, but it's already in the NCCN guidelines. Safety profile is a bit different from sacituzumab. We're seeing about stomatitis in about 50 to 60% of patients. But notably, I think what's unique about Dato-DXd versus some of the other ADCs is we see a lot more ocular toxicity. So keratitis, dry eye, increased tearing. And so any sort of ophthalmologic complaint on patients on Dato-DXd would be referring to ophthalmology urgently. GI nausea, vomiting are about 40-50% of patients. But the flip side is hematologic, where we don't have as much in the Dato-DXd arm compared to chemotherapy, which I think can be expected. Certainly compared to sacituzumab govitecan, we're seeing a lot more neutropenia. Again, not head to head, but different sort of flavors that we're seeing in the different ADCs. And so in the IO ineligible patients, we're choosing between sacituzumab govitecan or datopotamab deruxtecan. And increasingly, our choice is really coming down to toxicity profiles, what the patients have already received, what kind of organ reserve they have at the time of presentation, and sequencing going forward. Questions that we don't quite have answers to are, well, if we start with one, what happens if we go to the other? The studies that I mentioned in the HER2 positive slides obviously do not apply here, but I think the same principle of questioning the efficacy of topo-1 payloads sequentially when there's been resistance and progression on one in the first line remains an important question for us to explore. Again, just some implications for sequencing for today. PD-L1 positive or test for PD-L1 at diagnosis. I think that's NCCN recommended for any metastatic cancer, but especially in this case when we have sort of two divergent treatment paths. In PD-L1 positive patients, we're going to be looking at a sacituzumab and pembro combination. In the ineligible, we can look at sacituzumab govitecan or datopotamab deruxtecan. More or less, I think dealer's choice from the efficacy perspective, but also important to weigh in on patient preference and toxicity profiles of these two agents as well. In the second line, again, we don't have any prospective evidence right now, but would be thinking about the efficacy of sequential topo-1 payloads or directed treatments. If you're using sacituzumab in first line, is there going to be response to datopotamab in second line and vice versa? We don't have the data, but I think it's an important consideration when the other options that are left are essentially other chemotherapies. And of course, in germline BRCA mutated patients, always be thinking about PARP inhibitors at some point in your sequencing of care. So some takeaways, the biomarkers are remaining the default, whether you have hormone receptor positive, HER2 positive, or triple negative cancer. That PD-L1 status, that ESR1 status is going to be really guiding your next lines of therapies. I think what I'm excited to see going forward in the space is the diversity of payloads in the ADCs. We know we can target things pretty well, but are there the different menu of ADCs that we have going to be effective once we have progression on, for example, one topo-1 payload is another one going to be as effective? I think time remains, or the evidence remains to be seen, but I would be interested to see some other payloads under investigation. And again, just because we have some very, very impressive looking data on some second line studies, we do have to go back to think about the design of these studies and what questions they're actually answering. A PFS of what we saw in SERENA-6 is very convincing, but again, that's compared to keeping someone on an AI with a CDK4/6 inhibitor when we know that they're developing a resistance to that line of therapy. We'll see if the PFS2 data and the ctDNA clearance is going to be enough to convince the FDA, but certainly a step in the direction of trying to optimize our care based on not just on radiographic evidence, but also on circulating tumor DNA and liquid biopsies. I think I've reviewed a lot of these just now, but again, biomarkers are the answer to a lot of our questions. Just a case, we'll kind of vote by hands for some knowledge check from the presentation today, but we have a 58-year-old woman, postmenopausal, with HR positive, HER2 negative metastatic breast cancer. She's progressed in her first line with letrozole and ribociclib after about 14 months of combination therapy. And on progression, she was found to have a liquid biopsy with a PIK3CA mutation. Excuse me, and she is ESR1 wild type with a wild type PTEN status as well. So what will be the next second line therapy, best second therapy for her. Elacestrant monotherapy, capivasertib with fulvestrant, everolimus with exemestane, or continue ribociclib and letrozole and switch her to, continue ribociclib and switch the letrozole to camizestrant. So by show of hands, anyone have A, elacestrant monotherapy, B, capivasertib, C, everolimus with exemestane, the BOLERO2, and then continuing ribo and switch letrozole. So that's correct. We would, for the Capitella 291, we'd be switching to Capi with fulvestrant. Elacestrant would be if they had an ESR1 mutation, which this one patient does not have. C, from BOLERO2, we know can be effective, but we have a targeted therapy in answer B with capivasertib and fulvestrant with pretty robust PFS data in the PIK3CA mutated space. Of course, we'll see what the FDA also has to say about gedatolisib combinations as well. But I want to thank you all for your attention and for the opportunity to update you all on advanced breast cancer.
is that over time we're going to be able to see this. And at least with compared to the conventional markers we're using in terms of endocrine therapy, chemoendocrine therapy, and those patients with ataraxis high, we've got chemoendocrine therapy within this study called the UNIRAD study. We're seeing almost a 50% reduction in risk when they got chemotherapy based on the ataraxis score. This is again retrospective. It froze again. You know what's going to happen? It's going to advance like 10 slides. There we go. So, like I mentioned, we started incorporating this, and there are many companies, frankly, that are in the near future. But you get a nice report that I think is a dichotomous variable that you can discuss with your patients, et cetera. And it's my understanding right now, just in talking to my colleagues, but also talking to my patients, they're actually pretty open in this. So it'll be interesting to see if that interest is retained over time. So coming soon, actually it's come, which is being able to order this test to identify patients who might benefit from neoadjuvant therapy, which given the time that this takes to report back, the workflow is pretty fast. Right now, we send a slide to a CLIA certified laboratory. They take a picture of that slide, they put it into their framework, and we get an answer within 24 hours. A future state might be that the camera is at my institution, and the day the pathologist has cut the slide and made the agent slide, that same day we know this. Gene expression testing in the United States alone will take 7 to 14 days, and that delay can be hard for some patients. But globally, this is a real problem where you can't even get that type of testing. So this might close the gap there in terms of our surgeons being able to say, whoops, we got a problem here. I need to get them in front of a medical oncologist sooner than later. So that's on the digital biomarkers. But right now, the mainstay is still these endocrine genomic markers. And I won't talk a lot about these, but I want to highlight some of the things. In MammaPrint, there's an ultra low risk score. It's still not quite endorsed by NCCN, but it may help us find patients who are resistant on starting endocrine therapy to be able to say, listen, with endocrine therapy, it's 98%. Without endocrine therapy, it's 98%. There's not a whole lot of value for you for preventing a recurrence. It may still prevent a new event, but at least for recurrence, it may not. There's the H/I biomarker, which many of you will be familiar with. This is also known as the bioclasics or BCI score. This is essentially a dichotomous variable of two genes, HOXP13, IL-17BR, which interrogates both cancer, but also inside the tumor microenvironment, we get an understanding of macrophage polarization, lots of fancy words because I'm an immunologist. Anyway, that biomarker actually tells us with greater precision who's likely to occur after 5 years of entry. But we're not pushing the envelope because there's evidence suggesting that same biomarker will tell us who may actually benefit from upfront endocrine therapy. So this idea that for certain select patients, we may be able to offload any endocrine therapy for positive breast cancers is becoming a reality. So the NCCN guidelines have spoken to this already, at least for this idea that this test can be used in the extended adjuvant setting, but we may see updates showing that this could be of benefit in even earlier settings. And then this is just work from one of my trainees, and we've got the manuscript just submitted and got sent out to review. So we'll see how we do. But we wanted to look at, the top of biomarker. People sometimes substitute one biomarker for the next, but these biomarkers were developed with specific questions in mind, and they're not so flexible in terms of answering those different questions. So within a large registry that the biotheranostics company was putting forward, they looked at patients who had oncotype scores and also these BCI scores to see if we can identify patients who are endocrine sensitive versus not. So this is just the workflow on that 1,500 plus patients were looked at. And I'm not going to walk you through this entirely, but it's just to show you that when you have scored results, they're just telling you different things. Those patients who have endocrine sensitive tumors can, if you identify that by biotheranostics, you can't use a low risk oncotype score to tell you whether or not to extend it therapy, vice versa. So the oncotype, you hear this all the time. Oncotype, oh, it's low risk. I don't need endocrine therapy after 5 years. But the truth is, there's lots of biotheranostic high risk patients in that cohort that would benefit from sedative. So beware of conflating the results of what one thing says is low risk with what another might say is high risk. And then this is just to show you that difference. About of those oncotype low risk patients, we identified about 30% of patients that may benefit from endocrine therapy because they both have risky disease, but also sensitive disease. And in those patients who are defined as high risk, oftentimes patients are like, well, you got chemo, I probably got to give you 10 years of endocrine therapy. 40% of those patients may not benefit from that intervention. And reflecting the prior talk we just had about endocrine therapy toxicities and its harm, we want to be really careful about over-treating patients with endocrine therapy as well. And then there's new data coming out here as well. There are 2 recent manuscripts that are going to be updating sort of the recommendations around this. We know we have now been able to identify with this endocrine therapy marker that there are patients with extremely low risk of recurrence that we may be able to say to them, okay, you're not tolerating this endocrine therapy. Good news is you're also not benefiting from it a huge amount. So you have the option maybe to stop. It's actually not a small, inconsequential number of patients. It's anywhere, it's about 15 to 20, it's about 10 to 15% of patients. And then similarly, this is another data set looking at it. This is a Norwegian cancer research. You can see 14%, 16% of the patients falling into this category of maybe okay to not give endocrine therapy at all. And then prognostically, in the premenopausal setting, we're also now identifying patients who are oftentimes escalating therapy with ovarian suppression and endocrine therapy. But if your risk is low enough, you may not have to accelerate the endocrine therapy intensity in order to take care of those patients well. So this is all new data. The reporting is going to be coming out and reported in the summer, starting this summer by Theranostics. So if you order this report for your patients, you're going to be able to make more nuanced decisions, not just at the time where you're doing extended endocrine therapy, but the day you meet the patient, you can actually set better expectations on whether or not endocrine therapy is of as much value as we've talked about in the past. All right, this was now recently published and presented at ASCO 2026, and I still have my phone blowing up with texts from people around the country asking me for this. So I think it's still early days, but this is looking at patients who have node-positive disease, understanding that there's plenty of people with node-positive disease that don't need chemotherapy. We have with Oncotype the response bias data showing that up to 3 nodes of therapy, there's not much benefit in some patients, so maybe we can spare some of them. And with Manoprint, with their prospective study, we also know that they enroll patients with up to 3 nodes. Real question has been, for those patients with N2, is there real value for all of those patients seeing chemotherapy? So this is looking at that, now looking at the risk of relapse score, the Prosigna assay. And on that assay, and I've never ordered this assay, it's less than 60 is considered a low score, higher than 60 is a high score. So for those less than 60 people, they just provided endocrine therapy and OFS if appropriate. For those patients with higher than 60, chemoendocrine therapy, chemoendocrine therapy, and then there's a control arm where everybody just got chemoendocrine therapy. So what we really combined, comparing and contrasting is a high score, low score, and you've got the high score control arm. This is just the distribution of score, showing a nice bell curve distribution of those scores on that study. And then I think I don't have to show you. So in the complete per protocol population, for those patients with a low 60 score, we're not seeing any difference. It's less than 1% difference between the two. And then specifically focused on the ROR less than 60, the hazard ratio is 1.06. It's non-inferior. So we can spare some patients with node-positive disease chemotherapy, even when they're young women. And this is just showing you the forest plot on that. All those estimates are really hovering around 1.0, showing that there's no difference between the two. And in particular, I want you to look at the N2, pretty robust enrollment of greater than 250 patients in each arm. Hazard ratio is basically 1. All right, so that's biomarkers that we do on tissue. Now, the next thing that I just wanted to cover in terms of biomarker guiding therapy is ctDNA. So this is an old graphic from a View Medi I did some time ago paper, but essentially the idea historically with the first generation assays is you get the tissue of the patients, you do exome sequencing, typically 5 600 genes, right? And then you pick a few messed up ones, up to 16. and then say, I'm going to generate a primer probe set, this PCR, just for those genes, and then I'm going to measure them. If two of those signals are positive, they're ctDNA positive, so that's qualitative. And then quantitatively, we can report how many genomes theoretically that we're detecting in blood. And what we know in that assay is if you order it and it's positive, it's bad news. Many of those patients are going to progress. They're going to present with metastatic disease or local regional occurrence. However, if it's negative, the sensitivity wasn't low enough. In other words, if it's negative, some of those patients could still progress. But you're now falsely securing, ensuring a patient that you're in good shape when they're not. So you end up having to serially test them, et cetera, et cetera. So that first generation got us to where we are. It actually performs really well and adequately in some diseases, particularly like the GI tract cancers. But it's not performed particularly well in the breast cancers, in you guys' opinion. So the question is, can we improve on this? So now what's happening? Instead of just doing ctDNA on the exome, we are able to do a couple of things at scale. We can do whole genome sequencing at scale. And instead of looking at 16 genes, we can look at 1,000 genes. And then sometimes the mutations themselves are pretty labile. You can have clones that have a mutation and another clone that doesn't. A clone that had a mutation, so when you measure it and it disappeared, guess what? You're not going to see it anymore. But the other clones are still there. But what's not so labile are what we call structural variants. So these are genomic alterations where genes and parts of DNA that don't belong side by side are now sitting together. And those turn out not to be under selection pressure because we're not targeting them based on that. They're not actually necessarily drivers of cancer, so they're just passengers, and there's no reason why they need to disappear. Turns out we can measure those and see them more regularly. And so this is just showing you a company called it's a company called Saga, which no longer exists. They got acquired by a different company, but this is their assay, the Pathfinder assay, and you can see it's nearly 100% certain. If you detect the DNA, those patients are going to recur. Don't detect the DNA, they're not recurring. This is what we needed really to have be in place for us to do this. I will tell you, this company is the first that I'm highlighting here, but every company that's been developing these assays essentially has a version of this. And in the future, we'll be able to identify which of these assays work the best. But this is the level of quality that we're getting ctDNA at this point. This is what we frankly needed in breast cancer specifically, because breast cancers just don't shed as much circulating tumor DNA to the circulation. So this is a huge advance, and I think it's going to actually allow us to take care of patients better. Just an anecdote, I think I saved a life, sad say, in the last few weeks. Yeah, so I think it's pretty powerful. Okay, I'm going to leave the biomarkers now, and I'm going to actually move to some of the drug therapy studies that we've had come out in the last 6 months or so. So first, I'll start with Monarch and Now. So these are two studies of adjuvant treatment CDK4/6 inhibitors. Abemaciclib was the first to read out, particularly a high-risk patient population. As you can see, some of the characteristics, they were all node positive. They actually enrolled quite a number of node N2 and N3 disease. And if you had lower clinical risk but were still node positive, you had that high risk, sometimes have other high-risk features like the KS. This is a global study. In the United States, we identify high risk with things like mammoprint and oncotype. But those assays aren't available in many parts of the world. So they're using clinical markers, clinical stage to identify high risk. But I just got through telling you a few slides ago that there are patients with clinical high-risk disease that on gene expression testing is actually low risk. So keep that in mind, right? Like the study's a positive trial, but there are probably patients embedded in these studies that we just don't know who they are. So anyway, you see here the intervention was abemaciclib at the standard dose, 150 milligrams BID, 2 years, and it's a positive trial. And I'm going to show you some data showing it's a positive overall survival result as well. Natalie, a little bit different. Ribociclib, different dosing schedule than what we see in the metastatic disease setting. It's only 400 milligrams QD. It's 3 weeks on, 1 week off. And here they actually had some lower clinical risk patients, node negative patients, but you had to have other high-risk features, including a biomarker like a high MEM or a high type on this trial, 2 years versus 3 years of therapy. And so putting them side by side, just to show you the inclusion criteria, there's some differences. Natalie, in some ways, enrolled more patients, and so if you don't want to think about it, that's potentially say ribociclib. But there's some nuanced findings between the two. And there are patients who may say, I don't want to do this. Oh, I don't want my neutrophil counts to go down. I'd rather have diarrhea. The patient actually says that, but there are some things that change drugs. And so you may want to identify, based on the patient preference, which drug makes more sense for them. So this is the Monarch overall survival data. It's very mature now, and you can see almost a 16% reduction deaths on the Monarch E populations, high-risk population. It's an important advance. These are a lot, at scale, this is a lot of life saved. So that's what we're seeing in Monarch E. Now that's been reported and published already. Now, Natalie, this is the update on IDFS. And the thing that's reassuring here is that even though drug therapy stopped at 3 years, even after it stopped, these lines did not collapse. They didn't find each other. And they're continuing, if anything, they're continuing to separate. So the delta was 2.7, now it's 4.5 percentage points. It's a highly statistical p-value of 30% improvement. And this is the OS. So we're now 5 years out, we're only seeing a 1.6% delta, and you might go, oh, that would be worth it. Well, what's important to know is what's going on behind this value. So this is showing you all the different arms over time at 36 months, 44 months, now 57 months of follow-up. And what you're seeing is there's a lot more patients who are alive with metastatic disease who do not get the CDK4/6 prior to sickle. In other words, we will anticipate sadly more deaths in that arm over time. So I'm a betting guy, I'm a betting guy, this is going to be a positive OS at some point. So we're just waiting on that data to continue to mature, and I'm sure it'll be presented at an upcoming meeting. So the other intervention in this setting, of course, is instead of a CDK4/6 inhibitor, is there a role for targeting mutated estrogen receptor? So this is giredestrant. It's an oral SERD. And one of the questions is, first of all, is this drug just better than what we're doing now, better than an AI aromatase inhibitor, which is estrogen? We just destroy the estrogen receptor with an oral agent. The other thing is these drugs are highly selective for not just the estrogen receptor, but when there are mutations in the estrogen receptor. So this idea that a lot of the reasons why patients might have heard to the future is that they developed an ESR1 mutation, and then that renders them unresponsive to lowering this estrogen. You have to destroy the receptor in that setting. Can we forestall that event? This is a high-risk experiment. Successful. So this is a clean randomization, massive trial, 4,100 patients. They said clinically high risk, but you can see there were some stage 1 diseases. But if they did have stage 1 disease, there would have to be something else about their disease, like a high genomic marker, et cetera. So they're trying their best to do this. Again, globalized study, so not everybody's going to get a high risk. Right? But they conducted the study. The primary endpoint was IDFS, and then typical secondary endpoints, DFS, OS, et cetera, will all be reported in due time. With a large study, you hope to see parity between the arms, and I would argue we do. They're pretty well balanced. But I do want to highlight, though, in a globalized study, is the kind of what we consider American enrollment is oftentimes lower. So there's a higher proportion of Asian enrollment, 20% versus some of the trials as high as 50%. But sadly, a very low enrollment, for example, of Black African American patients. So only 2.5% on each side. Otherwise, you can see they're pretty well balanced. The US and Canada and Western Europe. I love how they put those three together, but the US enrollment is slow. So this is what we're seeing. You've got both the curves that are unaltered, but then the blow up to see kind of the differences. And here again, what you're seeing is over time a separation curve. It's not like they separate and stay. They're actually, if anything, the delta extend over time, kind of like the curves I was showing you before. Right now, the hazard ratio is 0.7, 30% improvement. Met its primary endpoint for IDFS. And this is what it looks like on this pre-specified categories. And it's a very consistent finding. Some of the error bars are bigger because there are smaller populations, for example, with stage 1 patients. But in general, all of those lines are hovering right around the overall estimate of 0.7. So that's always reassuring. And then this is the OS. There is some difference here. It's not statistically significant. It's very, very mature data at this time. So we're going to wait a long time. Now, the question is,
are we going to wait a long time for this data? And is the FDA also going to wait with us, or will they act on it earlier with the presumption that this will translate? We don't know the answer to that question. So something the company, I'm sure, is also very interested in knowing. So this is the update from ASCO. That was all from San Antonio. This is the update from ASCO, which is the breakout by menopausal status. Now, oftentimes clinically, we think about young women, high-risk patients as being the most at risk for recurrence. And clinically, that's not the case. But interestingly, the value of this drug was no different between premenopausal and postmenopausal. So you can see here the hazard ratio of 0.65 and 0.74. And then they gave us an update on toxicities. Good news is the majority of the toxicities are grade 1, 2, very few patients reporting grade 3. If anything, arthralgias a little bit more prominent, but generally you're looking at Mayo plots that are pretty well balanced between the two without a lot of interesting things going on. So we'll see as we get this out to patients to see if it's as tolerable as they're talking about in the study. So the endocrine therapy updates I want to share with you then. We have proven winners in BEMA, and I think we're going to see more data on ribo that supports its use in what we know as clinically high-risk patients. I didn't share it here today. There was an update at ASCO where they did genomics, sponsored by Novartis, to see if they could find genomic markers that found high risk or low risk patients. And guess what? So anyway, for the time being, we have no predictors of benefit or not from getting ribociclib. So if you're eligible for that trial, it's still the standard of care to offer for those patients. But again, there's new digital and other gene expression biomarkers are coming that may help us some of this decision making. And then the next question is an oral SERD really an option down the road for us in place of AI or tamoxifen? We're just waiting on regulatory action and maturity of the OS. So now I'm going to pivot to the other place where we've had lots of disruptions, which is in the neoadjuvant and adjuvant therapy space in HER2-driven disease. I always make that distinction because HER2 has become a biomarker when it's not even driving the disease. These are the old school, you've got a FISH amplified, a 3+ expression, and then we got to use HER2 targeting therapy. I generated a super simple algorithm. If you open up the NCCN guidelines, they're very confusing, right? There's like 50 options. So first question I ask when I see a patient, is it clinical or radiographically a T1N0 patient? If that's the case, the ATV protocol, which we've now had in place for a very long time, just giving adjuvant paclitaxel trastuzumab, continues to serve as well. If you remember, that data was presented on the podium again for overall survival, and we've been published, showing again at 8 years a 1 to 2% recurrence rate, noted overall survival from not giving chemo. So, sorry, from I said that poorly. It's a phase 2, it's a non-randomized phase 2, but 98, 99% is actually really. And then if they're not a T1N0, can we then think about neoadjuvant therapy? In the United States, standard is to give TCHP therapy. And then in Europe, a lot of patients still getting ACTHP, same in Asia as well. The next question is, if they got neoadjuvant treatment, did they get a pathologic complete response? And the answer is yes. Conventionally, we've just either been giving trastuzumab or trastuzumab and pertuzumab together in a combined shot called Phesgo. If not, historically, we've been giving adjuvant T-DM1 based on the Catherine trial, where we not only showed an improved invasive disease-free survival benefit, but also an overall survival benefit that emerged over time. And then lastly, if it was endocrine receptor positive in addition to HER2 positive, we add endocrine therapy. And then is there a benefit to adding a drug called tyrosine kinase inhibitor after the completion of the antibody therapy? So that was what we were doing about 6 months ago. Now this is not, it's no longer super simple. It got complicated on us. So in that, there's an interesting abstract from a Chinese author called IRSA, and I'm going to share that data, which shows maybe even a further de-escalation of the intensity in patients with T1N0 disease. If you're T2N0, we now have the optionality, this just got updated Friday, the NCCN guidelines, of giving PDXP followed by THP. And interesting guidelines, they said we could give THP first and then THP without any evidence, which kind of just sort of showed up on Friday. So we're still trying to wrap our heads around that.
And then in some patients, it may be even appropriate just to keep giving TDXD, but we can talk about that. Was there a PCR? Again, yes, nothing changes, but if no PCR with TCHP, for example, can we give those patients with residual clinical risk and antibody drug therapy? Historically, that's been TDM1. But if they had high risk disease, we can now offer TDXD or TDM1. The NCCN guidelines here and the FDA approval also funky. The FDA approval did not specify high risk clinical at baseline. They just said you can give it if you want based on residual disease. So the FDA is making this different than what the clinical trial reporting, and in some cases the NCCN is doing one step as well. So it's a little confusing, but I think what both groups are doing is they're giving us clinicians the power to look at the data and make decisions for our patients rather than hiring payers. And then was it ER positive, et cetera? I still think neratinib is an option for those patients. All right, so let's look at first IRIS. I love this trial. It's eventually 4 arms where they're looking at different interventions to de-escalate therapy in HER2 positive and other sort of contexts depending on hormone receptor status, et cetera. What they were able to show on the podium is the IRIS A cohort, which is in these really small up to T1C tumors that are HR negative or HR positive. Instead of giving taxane chemotherapy, can we instead give capecitabine, an oral chemotherapy agent that's generally well tolerated? This is pretty good. Very few recurrences of any kind. If anything, patients may have had another breast cancer, but not recurrence of the original cancer. No deaths, no distant recurrences. It's hard to beat that. This is what those curves look like, IDFS curves, but also disease-free, relapse-free survival curves. And keep in mind, IDFS, you got negative marks on IDFS for things like PCIS, other breast cancers. That would really face. So, and then interestingly, no events leading to discontinuation or interruption of study drugs. We use capecitabine. It can be a hard agent to be on. It's oral, but it's a limited exposure. It's not indefinite like we do in the metastatic setting. So this may actually be quite feasible for us. It was a Chinese-only study, so I'm not sure how we're going to incorporate that into our care. So this is now Destiny Breast 11. This is a study, as you can see, 3 arms on the study. The arm that was discontinued after data safety monitoring, that third arm where patients got TDXD for 8 cycles. Not because there was unexpected dangerous safety signals. It was going to fail the primary endpoint, which is improved PCR rate in the control arm. So we won't talk much about that today. But when you look at the other 2 arms, 320-ish patients on each arm. Patients were considered, quote, high risk to get on the study, and high risk is defined by either inoperable, sort of European definitions of inoperable. Our American surgeons will both have it. And then T4 disease or inflammatory breast cancer was also allowed to be enrolled. Patients either got anthracycline-based followed by THP, or they got TDXD followed by THP. And again, PCR was the primary endpoint, multiple secondary endpoints. The key secondary endpoint here for us to think about is event-free survival. Large study, global study, and again, just highlighting regions of the world, 47% of the world, which are happening in Asia. North America, 13%, and I will just tell you the US is a very small portion of that. So the question always is, how will this translate into a US-based population? Otherwise, pretty well balanced, nothing really sticking out to me that kind of raised concerns for me. A massive improvement in pathologic complete response in the intent to treat population. When you got TDXD, you had an 11% delta there. And then when they looked at based on HR positive, which is typically a harder disease space to get pathologic responses, you're seeing a 9% delta. And then the HR negative, a number I've never seen, above 80%, 83% of patients getting a complete pathologic response with the investigational regimen of TDXD, THP as conventional regimen, almost a 16% delta there. And then another way to look at this, I will warn you that this is something academic doctors like to do, but community practices often don't get this, is we can report something called a residual cancer burden score. RCB 0 is in essence a complete pathologic response. RCB 1 is a near pathologic response. And what you're seeing is a nice shifting of the proportion of patients that were going to end up with RCB to the RCB 0 and 1 class. And we also know historically that RCB 1 and 0 kind of track together. They both are groups that do well in terms of event-free survival events, whereas RCB2s and 3s don't. We don't do a lot of shifting in the RCB3, but the RCB2, and you'll see this soon, don't do well. So we want to definitely get more patients out of RCB2 if we can. And this is just looking at the forest plot. Again, most groups doing well here. What I found interesting is that curve for North America. I don't want to make too much out of it because it's a small curve, but it actually didn't look like this strategy made a difference there. Now, I think it's just really a small data set more than anything, but one wonders if there's something about these cancers that are a little different or how we're selecting patients to enroll on this studies. And again, what we think of high risk in the United States is really high risk and inoperable, right? We cut most everything if we think we can get it. It might be a definition thing. And then looking at the hazard ratio for event-free survival, neither have reached the median. It's very, very underpowered at this time, 11 and 18 events, but that hazard ratio is suggesting a trend in the right direction here as well. And then this is probability of EFS in the other arm, the TDXD alone arm. Interestingly, no difference here. So even though PCR was the main outcome of interest, we're not seeing an event-free survival difference with just straight up full-on TDXD. All right, and then looking at the TDXD versus THP, the patients with PCR and what they got afterwards, any adjuvant therapy, most patients getting it. Interestingly, about a 10% drop off in those patients without a PCR. You can see the distribution of therapies. TDM1 was the main therapy used in those patients that didn't get a PCR. But if you look, it's only 52, 56%. That's not standard of care in the United States, close to 100% in the US. So don't know how much of a difference that's driving, and we'll probably see a difference in the EFS curves as a result of that, but we'll see. And then in terms of AEs, glad to report no new safety signals, and if anything, fewer safety events because it was just a very compressed amount of exposure to TXD, and it's actually quite favorable in comparison to THP. Frankly, it was better tolerated than dose SAC to get TDXD. And this is the volcano plot. I think it reflects that. Nausea is something that's characteristically been assigned to TDXD as a toxicity. In the United States, we use 3 or 4 drugs to manage this. In the rest of the world, that is not the case. It's often 1 to 2 drugs. So I suspect in the US, we will actually do better in terms of GI toxicity with nausea. But otherwise, again, no new safety signals. If you get AC, which is definitely associated with neutropenia, and then followed up with THP as a chaser, you see a lot more grade 3 events there that are just avoided. So it's a possibility that we might use less growth factor support for our patients than real one in the United States. And then in terms of AEs leading to dose reductions, discontinuations, et cetera, I think it favored the TDXD. This is the TDXD alone arm versus the dose dense AC. I didn't mean to show that, so I'll just keep going. So this is looking at ILD pneumonitis. This is all 3 arms here. Overall, most of the events were grade 1, grade 2. Remember, grade 1, hold the drug, resolves, maybe give it again to the patient. Grade 2, don't do it again. Very few of those happen. Large study was looking at 4 or 5 patients for getting this. And interestingly, we saw as much in the dose dense AC THP. You don't typically look for ILD pneumonitis, but if you look for it, you're going to find it in some patients not getting THC, and that's what we're seeing here. Most patients resolved, and there was no consequence to it long term. And then in terms of cardiac toxicity, AC is a cardiotoxic agent, adriamycin is, so we certainly saw more events with that arms. This is something that tilts in favor of TDXD. And then when did the nausea events happen? Most of them were happening while they were on TDXD, and the dose dense AC rates are a little bit lower. But cycle 5 to 8, obviously, if you're still getting TDXD for 8 cycles, you can see some low events on that. You can see the distribution of patients getting 3 emetic regimens is actually pretty low in all arms. 40% is unacceptable even in the control arm. In the United States, essentially 100% of the patients would get a 3-drug regimen. All right, so that's in the neoadjuvant setting. This study was also presented at the same time. This is the Destiny Breast 5 trial, where instead of giving TDXD to all patients, We just focused on those patients that did not get a pathological complete response in addition to certain high-risk clinical features. And now instead of giving TDM1, the prior antibody drug conjugate that's the standard, could we think about TDXD as more effective drug head-to-head in the metastatic setting, to be more effective in the early breast cancer setting? So this is the NEAT study, randomized, clean study, 1,600 patients, massive trial, needed that kind of power because of the differences we were looking for. And here again, they had patients who had baseline prior to neoadjuvant chemotherapy. How are they being defined? They have inoperable early breast cancer. And again, many of those patients in the United States, but also they were in the operable setting, they have to have certain features. And then if you're in the operable setting, you still have to have positive nodes at the time of surgery if you got antibody therapy. So a couple different distinctions. Now the FDA approval, like I just said, didn't say it. They just said high-risk patients with residual disease, no qualifiers. So we have a different approval in the US than what that trial actually studied, putting that out there. The main endpoint here was IDFS again. So this is looking at the two arms side by side, highlighting again, very global study, Asian enrollment, almost 50%, Black African enrollment, 2.716%, very low. I think that's reflected by the fact that there was very few enrollments in the United States, North America, plus Australia by two different continents here. Got to 7 and 8.8%, 57 and 72 patients. So very few US-based patients on this study is what I would suspect. Otherwise, well-balanced in terms of types of therapies. 80% of patients getting pertuzumab in the neoadjuvant setting. Prior study Catherine trial, that was not the case. It was only about 10 to 20% at that. So this is a more contemporary population that reflects our current practices in the United States at this time. And then most patients getting taxanes, some patients getting anthracyclines in that neoadjuvant setting. The other question is, would it be safe, given that this drug has a pulmonary toxicity profile, to give concurrent radiation therapy? Rather than dictate that, they had concurrent sequential observations of radiation therapy to look at the relationship of ILD and pneumonitis and whether or not it is being driven more in the combination of the two as opposed to the same sequential arm. So we'll look at some of that data as well. So this is the IDFS outcome. This is actually a massive improvement as well. So historically, when we did Catherine, we improved for those patients without pathological complete response. We made a 10 percentage point improvement at hazard ratio of a 50% improvement. So round number, we got from 20% to 10% of patients recurring. Here, you're looking at patients who are on TDM1 with a higher risk clinical profile, right? You have 84% of the patients who are recurring, and now it's only 92% of TKs. So another improvement in this hazard ratio with patients who are clinically even higher risk. And remember, all these patients, most of them also saw pertuzumab in the neoadjuvant setting. So these are more heavily pretreated and worse acting disease at baseline, and you're now still seeing a bigger improvement here. This is also a practice-changing arm. And then in terms of pre-specified subgroups, most subgroups, the hazard ratio is hovering around that 0.47. The tiny North America, Australia, get a little bit, crossing, but I won't make too much of that. And then in terms of where the IDFS events were happening, you can see 50 events versus 102. In terms of distant recurrence, 42 versus 77. So the main event driving these recurrences were distant recurrences. So as medical oncologists, that's what we're trying to prevent. Interestingly, CNS recurrence, 17 and 25, right? Or 17 and 25 events total. One of the things we observed in the metastatic setting is that THC is actually a pretty effective agent for being a big bulk monoclonal therapy-based drug at preventing CNS recurrences. And the idea historically has been, well, those drugs won't work. But we've always thought about the blood-brain barrier. What we really have to think about is the blood-brain met barrier, which is a very different thing. It turns out these drugs actually get across many different diseases. In this setting, these are patients who best neurology do not have metastatic disease CNS. So this idea of are we able to prevent metastases is kind of intriguing, but we don't know this yet. So yes, we'll continue to track this. And then disease-free survival mirrored what we saw in invasive disease, IDFS events as well. And And then in terms of other endpoints, brain met free interval, very few events here, but you see the hazard ratio showing a 36% improvement there. And then overall survival, 2.9% maturity. This is a very immature outcome, but it's tilting in the right direction as well, 40% improvement at this time. And then median duration of therapy. You know, one of the big questions was, can everybody get 14 cycles of TDXD? Because that's our intent, to get 14 cycles of TDM1. Surprise, surprise, we can't get TDM1. 9.8 versus 9.7. And you can see when patients are essentially able to discontinue therapies, 14 cycles is only given to 70% of patients on both arms, 72, 76%. And then what were the AEs we're observing? Just in terms of the overall proportion, pretty much everybody experienced AEs. Serious AEs were kind of generally well balanced, but a little bit more on the TDXD side, leading to drug discontinuation, a few more discontinuations. ILD pneumonitis, you see 10% versus 2.5%, and then the drug interruptions, et cetera. So slightly more going on in the TDX, but overall no new safety signals that were, and not a whole lot different than what we're seeing in other contexts. This is a tornado plot. Again, nausea seems to be the big one. I still think in the United States, we're going to do better with this. Haven't seen a breakout of this yet. There's a little radiation pneumonitis marker there. You're seeing no difference. These are externally adjudicated events and investigator adjudicated events. And what we're seeing is that radiation pneumonitis was common. And remember, we don't look for this. A lot of these were grade 1 events. These are radiographic changes that, based on where the radiation beams are shot at the patient, see behind that lung, behind that beam, where the haziness happened in the scan. We're reporting that. These are high rates, but we would normally not see this. But the majority of events were radiation pneumonitis. And it's very common and similar on both. Now, looking at this ILD adjudicated drug-related events, obviously with TDXD, you're seeing more there. There were 2 grade 5 events that 2 patients with early stage breast cancer died on this out of 800 plus patients. I'm being honest with myself, if I compare sequentially 800 patients with high risk HER2 positive disease, I will lose 2 or more patients. That's just the reality of the disease. So this is not, while it's sad, it's not a shocking number to see in this high-risk situation. LV dysfunction, similarly, not that different between the 2 arms. So that was the TDXD data that was presented from the podium. It's now led to a FDA acknowledgement and NCCN guidelines, et cetera, et cetera. Now, we have some additional data that's presented at the podium at ASCO, looking at a specific question about safety of current radiation. I won't walk you through this entire thing, but essentially, patients had a baseline CT scan, and then depending on whether or not they had sequential therapy versus non-sequential versus concurrent therapy, the timing of when they got additional CTs changed. So if you're on the drug, concurrent therapy, radiation, you got it more frequently. If you got it sequentially, you just had the next scan when you started the TDXD, and then you got it. So patients had a lot more scans if they got it currently. And in general, these are the adjudicated drug-related ILD on TDXD. You don't see that much difference between sequential and concurrent, so that's reassuring. And then in terms of drug-related versus investigator-reported, we're not seeing that much difference either of those patients for a second event after resuming for discontinuation. Remember, most of the events were low grade, so we weren't seeing any downstream consequence of that. And then this is investigator-reported events for radiation pneumonitis. So pretty common, like 30% of patients, but few of them led to any, permanent discontinuation of treatment because of them. So both treatment arms, adjudicated drug-related ILD was influenced by region, Japan, saw more, and interestingly, baseline renal function. So there's some interest in looking at this more deeply. So just to go back on this, in the United States, if you ever have a chance, go talk to a radiation oncologist, right people. They use quite a bit of imaging in the United States, and they can show you precisely how much lung is getting hit by radiation. I will tell you, it's just a sliver of tissue. So radiation in the United States is quite uncommon, other than outside of that little sliver of tissue. I'm not worried about this. It's an editorial opinion, and I don't think we need to look for it as often as they did on the study. All right, so conclusions on the HER2 positive patients, or just in general. They're evolving approaches. So the accuracy biomarkers So defining the problem better so we can be more precise. Precision in oncology is not just about the drugs, it's who we focus. And we're going to see, I think, improvements because of those biomarkers. In the ER-positive disease, we've always had these solid options. We've layered on better drugs to make the endocrine therapy work better, in addition to, for example, the CDK4/6 inhibitors. And now can we mix and match it an oral SERT for some of those patients? And how do we sort that out at the end of the day? We will have data coming out soon on being able to get oral SERTs along with a CDK4/6 inhibitor in the adjuvant setting. It's going to take a little while, but we'll have it. And then in HER2 early stage disease, it's just massively different than the standard 6 months. We have a lot more options. And I'm hearing, I've been doing advisory meetings and other things for a lot of stakeholders, trying to understand how this is going to play out for us. And it is a Wild Wild West. Every doctor has their own idea of what they want to do and for each of these patients. And we started incorporating into our practice as well. And so we'll report back on how well that's all playing out for us. That's a lot of data that swam through it. Happy to take questions, guys. Thank you.
Great. Hello, everyone. My name is Sarah Werner. I am one of the gynecologic oncologists here at UIC, coming to you virtually to discuss my updates in gynecologic oncology. And today we'd like to just talk about circulating tumor DNA in the sphere of GYN oncology, some current evidence, and certainly some future directions. I think ctDNA is a rapidly evolving piece of medical technology and is becoming increasingly relevant in oncology. And so the goal here really is to review where we are, what we know, and where this is going. Okay, great. Sorry. I have no disclosures. And so again, really our objectives are to review what ctDNA is with an emphasis on a historical perspective, different types of ctDNA, current usages in other solid tumor cancer types, data for use in GYN oncology, and then any future considerations that we may have for this. So what exactly is ctDNA? So ctDNA, or circulating tumor DNA, consists of small fragments of DNA that are shed by tumor cells into the host bloodstream. And this represents a subset of actually the broader pool of what we call cell-free DNA, which includes DNA released from normal cells throughout the body. Importantly, ctDNA levels can actually, as we'll get into, often reflect tumor burden and thus can actually provide insights into tumor biology. And this has really led to the concept of a minimally invasive approach that can help characterize disease, monitor response to therapy, certainly detect residual disease, and potentially identify recurrences earlier than our conventional methods. And so at its core, ctDNA is really like this blood-based biomarker or minimally invasive window into the molecular status of a patient's cancer. And so a brief historical perspective to take you back in time. To appreciate where ctDNA is today, it's useful to really understand how this has evolved. And the story actually begins much earlier than many people realize, including myself. Cell-free DNA, or cfDNA, was first described actually in the bloodstream back in the 1940s. And although at the time there was really no clear understanding of its clinical significance, and so then several decades later, in the 1990s, investigators really began identifying tumor-associated genetic alterations in patient plasma. And this was a pivotal discovery. It really demonstrated that cancers shed detectable DNA into circulation, creating the foundation for what we now call ctDNA analysis. The next major inflection point came with advances in the next generation sequencing and highly sensitive molecular technologies. So these innovations really dramatically improved our ability to detect rare tumor-derived DNA fragments among a much larger background of normal cell-free DNA. And then over roughly the last decade, the field has really expanded exponentially with the emergence of minimal residual disease, or MRD, detection. And rather than simply identifying the presence of cancer or no cancer, ctDNA really increasingly is being used to detect microscopic residual disease, or MRD, after curative intent therapy. It can also really help us monitor then treatment response after curative intent, and certainly our hope is to help identify recurrences earlier than the conventional imaging that we do have in many settings. So in many ways, the evolution of ctDNA really, reflects this convergence of advances in cancer biology, genomics, and sequencing technology. So it's really like a wonderful collaboration between multiple aspects of medical technology, and that has become this transformation of this observation that was made nearly 80 years ago into really a powerful tool for precision oncology. So there are a few types of ctDNA. First we have is tumor-informed or personalized assay DNA. This tumor-informed assays, they start with actually sequencing the patient's own tumor and then tracking a customized sets of mutations in plasma. And because scientists are really looking for known tumor-specific variants, these assays generally offer the highest analytical sensitivity, particularly when disease burden is low. The trade-off for tumor-informed is certainly they require access to tumor tissue for sequencing, which can increase cost and then certainly turnaround time. The second type is something called tumor agnostic or panel-based assay. These assays do not require sequencing, and so instead they use a predefined panel of commonly altered genes that make up a traditional tumor type. This makes them faster to deploy, easier to scale. However, because they are not personalized, the pitfall here is sensitivity may be lower in settings with low ctDNA fractions. And then lastly, something that's very interesting and certainly unique to GYN oncology is HPV-based assays. So this is being implemented in our cervical cancer patients, where we have this unique opportunity because the viral genome of the oncogenic virus itself actually serves as a highly specific tumor marker. So rather than tracking somatic mutations, these assays actually detect circulating HPV DNA, which may simplify our assay design and certainly provide excellent disease specificity. So our key takeaway really when we're dealing with the first two is, in general, tumor-informed approaches maximize sensitivity, and our tumor-agnostic approaches really prioritize a speed and scalability and broader accessibility. So why does ctDNA matter? Why is it really so much interest, I guess, in oncology? And fundamentally, it's really because it gives us a minimally invasive way to track tumor biology in real time. So after surgery or definitive therapy, one of our biggest challenges as oncologists is to determine who truly has microscopic, minimal, or molecular residual disease or MRD. And imaging alone after a curative intent often really lacks the sensitivity to detect disease at that scale. And ctDNA really offers this possibility of identifying residual tumor burden at a molecular level before it even can become clinically apparent. And so both for clinicians and developers and within the industry, MRD represents a potential tool really for risk stratification and certainly treatment selection, which we'll get into momentarily. Another point of interest is recurrence prediction. And so one of the most compelling findings across multiple tumor types is that ctDNA can be utilized to detect recurrence months before radiographic progression. So this lead time creates an opportunity to intervene earlier. And I actually put a little question mark after that, as I think one of the big questions from this information is exactly when and how acting on the information will improve in patient outcomes. And so we're not sure about that if there is a benefit yet, but that's something that we're aiming to investigate. And as gynecologic oncologists, this is particularly relevant because many of our surveillance strategies actually rely on imaging performed at non-discrete time points. Another way ctDNA can help is to monitor treatment response, and levels can change rapidly in response to therapy, which often predicts changes that we see on CT or imaging scans. This creates the possibility of using ctDNA as a dynamic biomarker to assess whether treatment is working, rather than waiting several months for radiographic evaluation. And lastly, beyond measuring disease burden, ctDNA can actually provide insight into tumor evolution. As selective pressure from treatment drives clonal changes, emerging resistance mechanisms may be able to be detected in plasma of ctDNA. And this can then help guide subsequent therapy and support more precision oncology. And so taken together, really ctDNA has the potential to move oncology largely from a reactive model, waiting for disease, for example, to become visible on imaging or waiting for patients to become symptomatic, to a more proactive model based on molecular detection and real-time monitoring. The key challenge now is really determining where these signals meaningfully change patient outcomes and how to best integrate them into routine care. And so we've been dancing around this concept of minimal or molecular residual disease, or MRD. And so just to give you kind of a schema of visual aid here, MRD detection is really widely used and has been widely used in hematologic malignancies, but it's the idea that cancer is persisting after treatment that cannot be detected with current imaging tools like CT, PET scan, et cetera, that looks for more occult metastatic disease. And so what you can see is with these fluctuations in levels is that MRD can be a diagnostic threshold here before there's a clinical or clinical diagnostic threshold that can be seen at much higher levels of tumor load, where patients are symptomatic, or certainly there are lesions on a CT scan that then lead to cancer progression. And so MRD really may now actually be used in solid malignancies to help us monitor these tumor burden levels. And so some clinical applications here are when we think about combination of surgery and chemotherapy is using detection of minimal disease for early recurrence monitoring, whether patients are responding upfront to neoadjuvant therapy prior to going for surgery, and certainly with metastatic relapse. If patients have disease recurrence, using ctDNA levels as a means for us to monitor patients for the efficacy of the treatments we give them. So there's multiple strategies to employ here. In multiple studies, in multiple arenas, we have evidence for ctDNA as a predictive biomarker from MRD and disease relapse. Has been seen in colorectal cancer and non-small cell lung cancer, urothelial carcinoma, and breast cancer. They'll get into a little bit more of specifics, but patients who have across the board negative circulating tumor DNA after curative intent across all 4 cancer types, solid cancer types, have a very low chance of recurrence, whereas those who have CT positive after curative intent without evidence of macroscopic disease on conventional imaging standards will have much higher rates of recurrence. So breaking it down a little bit into some studies that I found particularly helpful when we think about gyn-onc, the first is ctDNA in colorectal oncology, and this is really highlights the dynamic trial. So one of the landmark studies, which patients with stage 2 colon cancer who've been completely resected used minimal residual disease, or MRD, as an adjuvant tool. And it's frequently cited because it really was the first step that moved again beyond observational data, right? Beyond just collecting ctDNA at various time points in a patient's traditional treatment course. And it actually tested a ctDNA guided treatment strategy. So as I mentioned, this trial enrolled patients with completely resected stage 2 colon cancer, and then used tumor-informed ctDNA assay after surgery. And rather than relying solely on conventional clinical pathologic risk factors from the colon specimen, adjuvant treatment decisions were informed by postoperative ctDNA status. So this provided some of the strongest predictive evidence that ctDNA can actually function as a clinically meaningful MRD biomarker. And as I mentioned before, the key finding was that patients who remained ctDNA positive after surgery had a substantially higher risk of recurrence than those with ctDNA negative patients. And perhaps, really the most practice-changing aspect of the study was, again, demonstrating that ctDNA a guided approach to treatment was feasible in a real-world setting. So those who then underwent adjuvant therapy with ctDNA positive selection, ultimately those patients did better, and it was a good selection tool for these patients. So simply not just a prognostic marker, but it may actually be an indicator of persistent tumor burden and those patients who may benefit from adjuvant therapy after a complete resection. For those of us, outside of colorectal oncology, the dynamic trial really serves as a proof of principle, right? So it shows us that ctDNA can move beyond prognostication and potentially actually become a decision-making tool. And many of the ongoing ctDNA studies in gynecologic cancers, as well as other solid malignancies, are essentially asking whether we can replicate this model in different disease settings. So moving on to urologic oncology, there are a couple of interesting applications. While colorectal has certainly arguably led the field, some of the most exciting developments are actually coming from both bladder and prostate, and for different reasons. In bladder cancer, the major focus has been in MRD detection after cystectomy in early stage bladder cancer. So the IMvigor11 trial is one of the most important ongoing examples of this. This was a phase 3 trial, which used tumor-informed ctDNA assays to identify patients with MRD after cystectomy, and that would thus direct adjuvant immunotherapy. So the study was really important. It tested the fundamental question raised by dynamic and colon cancer, which was, can ctDNA identify patients who would truly benefit from additional treatment? And similarly, can it then be used to de-escalate adjuvant therapy for those who would not benefit? And as you can see, there's obviously a benefit in the CT positive patients who then received immunotherapy, the atezolizumab. They did better. In prostate cancer, actually, the emphasis is much different. Rather than primarily focusing on MRD, ctDNA is being used actually to characterize tumor genomics and identify mechanisms of resistance. And because metastatic prostate cancer often is genomically very heterogeneous, liquid biopsies really provide comprehensive snapshots, better than a single tissue biopsy. And one of the most clinically relevant for them is the detection of androgen receptor alterations that emerge under treatment pressure. And so ctDNA can identify androgen receptor amplifications and mutations and other resistant mechanisms that then may influence treatment pathways. And so the take home here is really urologic cancers showcase two kind of complementary applications of ctDNA. In bladder cancer, the focus is increasingly on MRD detection and treatment selection after definitive therapy. And in prostate cancer, ctDNA is becoming an important tool for monitoring disease response and identifying resistance mechanisms. And for those of us in gynecologic oncology, these experiences are particularly instructive because they demonstrate ctDNA as both a marker of residual disease and a window into tumor evolution, and concepts that are now actively being explored across ovarian, endometrial, and cervical cancers. Some key lessons, really just to synthesize it nicely. ctDNA is a strong predictor, a strong prognostic marker for us. Clearance of ctDNA, it clearly correlates with improved patient outcomes. This can also enable therapy escalation or de-escalation after surgery. And this does require, though, prospective validation. So let's move into gynecologic oncology. The short answer really is that evidence is growing rapidly across, I would say, our biggest cancer types, so ovarian, endometrial, and cervical cancers. But unlike some of the other tumor types, ctDNA remains still largely investigational and has yet to be incorporated into routine clinical decision-making. So for ovarian cancer, most of our ctDNA literature is focused here, and studies have shown that ctDNA can lead to detection can lead to molecular recurrence detection before clinical or radiographic relapse, and may provide information that complements our traditional biomarkers, such as our CA125 tumor marker. There's also significant interest using ctDNA to monitor treatment response and thus identify emerging resistance mechanisms. In endometrial cancer, ctDNA appears promising for identifying patients at higher risk of recurrence following primary treatment. And so several studies have demonstrated that post-operative ctDNA positivity is strongly associated with subsequent relapse. And there's growing interest in whether ctDNA could eventually help refine adjuvant treatment decisions beyond clinical pathologic risk factors similar to the dynamic trial. And then in cervical cancer, it's particularly interesting because HPV-associated tumors provide unique circulating tumor biomarkers. Rather than, again, tracking tumor-specific mutations, we use HPV DNA directly, and early studies that are suggesting this approach may be useful for treatment monitoring, recurrence detection, and MRD assessment. Despite these encouraging data, we've yet to reach the point where ctDNA testing is routinely recommended for surveillance or treatment decision in most gynecologic cancers. It hasn't fit our algorithm just yet. The evidence is currently insufficient to support widespread adoption. Many of the studies remain small, retrospective, or observational. So some of the take-home messages here is the field of gynecologic oncology is moving from that proof of concept towards clinical application. And ctDNA has really demonstrated a clear biologic and prognostic value across these cancer types, but we're still awaiting some more prospective studies needed to define exactly how these assays should be integrated into routine care. So for ovarian cancer, this is this is a slide, where I really kind of lean into the balance of promise and limitations, because ovarian cancer, I would say, is arguably one of the most biologically challenging diseases for plasma ctDNA, despite being one of the diseases that we are desperate for better biomarkers. Across multiple studies, ctDNA levels certainly correlate with disease burden. This has been proven in ovarian cancer. Higher ctDNA levels are associated more with advanced stage, larger volume of tumor, and worse clinical outcomes. And longitudinal changes in ctDNA often are mirroring response to treatment, which is making it an attractive biomarker. But one of the most appealing applications is really in recurrence monitoring. And so several studies suggest that ctDNA can identify molecular recurrence before CA-125 even begins to rise. And importantly, ctDNA also provides genomic information about the recurrence disease, which obviously CA-125 cannot. That said, I think the magnitude benefit varies between studies, and we still don't have prospective evidence that shows that acting on earlier ctDNA improves outcomes better. But one of the other studies that I wanted to mention was Tabuni et al., which looks at, well, it was actually, was published this year in our Journal of Gynecologic Oncology. Tabuni et al. Looked at ctDNA status of patients who are in a PARP inhibitor maintenance after primary therapy, and noted that this was a strong predictor of disease progression compared to standard CA-125 or BRCA or HRD status. And so in other words, tumor-informed ctDNA status is highly prognostic. And to further this thought, just at our national conference this past March, O'Brien et al. Demonstrated that longitudinal ctDNA monitoring provided real-time insight into treatment response and recurrence, where patients who had negative ctDNA post-adjuvant chemotherapy did not demonstrate disease recurrence during a median study follow-up time of 17 months, which is excellent. Conversely, the cohort of patients who had positive ctDNA after adjuvant chemotherapy, after curative intent, all recurred within a median time to progression noted to be about 3.5 months, which is fairly significant. One of the limitations, as I alluded to before, was about the biology of ovarian cancer. And so the biggest challenge, particularly for those that are diseases that are confined to the peritoneal cavity, is that they have relatively low levels of shedding of DNA into the bloodstream. So unlike colorectal or bladder cancer, where tumors often have direct vascular access, ovarian cancer frequently remains compartmentalized within the peritoneal space. As a result, negative plasma ctDNA result may not necessarily mean absence of disease, but it certainly can be something that is important to investigate further. As gynecologic oncologists, we've all certainly cared for patients whose CA-125 imaging and symptoms don't exactly tell the same story. So I'd like to just use a little bit of a real world application of a patient of mine where I've used ctDNA as a way to help inform my patient care. So this is patient AR. She's a 47-year-old. She's a BRCA1 mutant. She had a past medical history of alcohol-induced liver cirrhosis. She has chronic ascites from that, which can be challenging in the setting of ovarian cancer, which also makes ascites. She also had a mildly elevated CA-125 after a primary treatment, which I will get into in a moment, and was diagnosed with a 3A high-grade serous ovarian cancer. She received 4 cycles of neoadjuvant chemotherapy. She then had her debulking surgery and 3 cycles of adjuvant, and then was on a maintenance PARP inhibitor for about 8 cycles. Her imaging started like noticing like peritoneal thickening and maybe some increasing in her carcinomatosis. Her CA-125 at that point has been stably kind of in the 50s at that point. This was her nadir after her initial treatment. She was started on carboplatin gemcitabine as she was platinum sensitive. She received 5 cycles of that. At cycle 4, the decision was made to proceed with Signatera, and she was found to have elevated levels to 1.35. She was asymptomatic. Her CA-125 was not budging. When she came back for cycle 5, 3 weeks later, her Signatera at that time was jumped up from 1.3 to 70.3. In the mix of all this, the decision was then made to get a CT scan based on this change. And her CT chest, abdomen, pelvis after cycle 5 demonstrated stable disease. And this was, you can see the dates here. This was just about 12 days after her Signatera was drawn. And, really, my partners and I, got together and then discussed this, what to do. Are we calling her progression of disease? We know that her CA-125 hasn't been a good trend and that her scan demonstrated stable disease. However, we're anticipating her to have a change in her scan, that we anticipate that this ctDNA, as the data has been suggesting, has shown a change in her tumor disease burden prior to change on the CT scan. And this is vital because we're now determining whether or not she has platinum-resistant disease, which once a patient with ovarian cancer becomes resistant to carboplatin, the landscape and their tumor biology becomes clinically much more aggressive and much more challenging to treat. And oftentimes patients never achieve meaningful remission at that point. And ultimately, I can say now, because it's time has passed since the slides, but her repeat scan demonstrated progression of disease, and she is now diagnosed as platinum-resistant disease. So this is just highlighting again the ctDNA's ability to detect changes in the disease landscape prior to our conventional methods. Moving on to endometrial cancer, it's actually one of the more promising areas for ctDNA within gynonc. And unlike ovarian cancer, where there's low shedding, which can be a major limitation, many endometrial cancers appear to release sufficient tumor DNA into circulation and making longitudinal monitoring very feasible. And so several studies, have demonstrated that ctDNA can identify molecular recurrence again months before radiographic progression becomes apparent. This is particularly attractive in endometrial cancer because our current surveillance really relies heavily on symptoms and physical exam findings, et cetera, including like vaginal bleeding and imaging once recurrence is suspected. And one of the most exciting areas also is about risk stratification. Multiple studies really have shown that patients also with detectable ctDNA after surgery have substantially higher rates of recurrence, similar to that of the dynamic trial. And that raises the possibility that ctDNA could eventually complement or even refine traditional clinical pathologic risk factors of who would receive adjuvant therapy after curative hysterectomy. The INSPIRE trial was also very exciting because this helped us utilize ctDNA as a tool for validation for checkpoint monitoring. This was actually a pan-tumor trial, so it's important to note that it wasn't just endometrial cancer, but all pan-solid tumors who underwent checkpoint inhibition maintenance therapy. But it did demonstrate that there was a benefit of patients who may have been able to come off of immune checkpoint therapy based on persistent negative ctDNA blood tests. And so as with many ctDNA applications, I would say one of the major unanswered questions is whether acting on ctDNA results will change our patient outcomes, right? We know that it's prognostic. We increasingly know that it is from multiple tumor types. So we still need prospective intervention to demonstrate that ctDNA guided management also improves recurrence-free or overall survival. And so moving on to a real-life application in endometrial cancer, this is my patient MS. She's a 59-year-old with morbid obesity, so her BMI was 77 with suspected stage, not stave, 3C grade 2 endometrial cancer. This is based on a PET CT I had for her. So we gave her 4 cycles of neoadjuvant chemotherapy. This poor lady had extremely poor tolerance. She had multiple hospitalizations. Essentially, after every cycle we gave her, my partner and I ultimately made the decision to take her for a hysterectomy with a full understanding of risk, given her morbid obesity. And actually, her final pathology looked excellent. She was downgraded to a grade 1. There was less than 50% myometrial invasion. Her uterus looked good. We did not go after any of those lymph nodes, just given her supramorbid obesity and reducing surgical time. So the decision was made to implement circulating tumor DNA again. She had pre-surgical Signatera. I say that these are pending, but I apologize again. These slides were dated from a month ago. Her pre-surgical Signatera was 5, so some residual disease. We took her for her hysterectomy. At her 4-week postoperative visit, we got a postoperative Signatera. It is now 0. Which is really exciting. So we think that our assumption is that reflective disease was actually just residual from the tumor inside her uterus and not based on metastatic systemic disease, reflecting efficacy of the neoadjuvant chemotherapy she received happily, despite her suffering. And actually, I put question mark, but we're going to actually put her on surveillance with Signatera. Initially, I wanted her to go on some checkpoint, some pembrolizumab checkpoint maintenance, but she actually didn't even tolerate the Keytruda either. And so we'll save that in our back pocket should she recur, and we'll implement Signatera monitoring every 3 months for her. Lastly, just touching on cervical cancer. Among the gynecologic cancers we discussed, cervical cancer actually represents one of the most compelling cases for our biologic target of HPV directly. And that's a benefit and actually a unique opportunity. So when circulating HPV DNA is detected, we're essentially measuring tumor-specific signaling rather than relying on, non-specific markers. And one of the most promising applications of this is disease response assessment during chemoradiation in locally advanced disease. And several studies have shown that HPV DNA levels decline rapidly in patients responding to treatment. Conversely, persistent detection after initial therapy may actually indicate, again, minimal residual disease and higher likelihood of treatment failure. So this creates the possibility of identifying patients who benefit from closer surveillance or, again, future investigated strategies. Similar to what we've seen in colorectal and bladder, HPV ctDNA also may function as a molecular residual disease marker, and also can help us, really detect recurrence risk as seen here. And so briefly, just to discuss sort of like a project of mine and then ways that I'm implementing this with our cervical cancer patients, I would say, unfortunately, UIC has this unique niche of having a lot of cervical cancer, unlike many other universities and many other mainstream academic centers. And this has really afforded us the opportunity to implement tumor-informed ctDNA as an investigative option for patients with all stages of cervical cancer. So the proposed clinical model is broken down basically by early stage and locally advanced or metastatic disease, but really the gestalt is getting a baseline at diagnosis, and either a post-op or a mid-treatment if it's locally advanced, and then end of treatment if there's any adjuvant therapy looking for MRD. Obviously, the patients will enter surveillance or maintenance, and ctDNA would be drawn at every time point for the first 2 years, every 3 months. We would really utilize this because, unfortunately, unlike some of our other tumor types like endometrial cancer, patients who have vaginal bleeding at time of recurrence, or ovarian cancer, patients who have abdominal pain, bloating, ascites accumulation, nausea, vomiting, etc. Those are good tells from a patient's symptom perspective that a disease is recurring. We don't really have a good one for cervical cancer. So my schema sort of revolves around if ctDNA becomes positive, having reflex testing. We would get confirmation with a repeat test, but certainly use that to help guide our imaging. And right now, we're really planning to treat only if radiographic disease and pathologic disease is confirmed. But I would also argue that we would introduce better surveillance and possibly even include discussion for adjuvant therapy for those who have MRD after curative intent. One of the questions that I have that certainly can be impacted is this the strategy change post the Conserve and Shape era. Those are two landmark trials that looked at early stage cervical cancer and extrafascial or simple hysterectomy. And that's a question that we have to keep in the back of our mind as we're de-escalating early stage cervical cancer management. Does that change how we want to monitor and survey them? Let's just get into some biologic limitations briefly, and some other considerations. Certainly we have compelling evidence that this is effective, but so we want to be careful about any pitfalls and limitations. Um, One is low tumor shedding. This is what I mentioned. Not all cancers release DNA to the circulation at the same rate. And so tumor type, volume, vascularity, metastatic site, these all influence the amount of ctDNA that's available for detection. It's particularly relevant, as I mentioned before, with ovarian cancer. And as a result, I would argue at this point that a negative test doesn't necessarily mean absence of disease at this point until proven otherwise. Then certainly false negatives, right? Patients can have microscopic residual disease or even radiographic evidence recurrence while remaining ctDNA may be negative. And this is why ctDNA at this point should be viewed, I would argue, as complementary to, not a replacement for clinical assessment, imaging, pathology, and other biomarkers. As clinicians, one of the most important principles, obviously, is understanding that a negative result doesn't provide absolute reassurance. And I said the third biologic challenge is tumor heterogeneity. Cancers are dynamic. They're composed of multiple subclones that evolve over time, and especially under treatment pressure. So a ctDNA assay may not capture every biologically relevant clone, particularly if certain subpopulations shed little DNA or emerge later during treatment. And this becomes especially important when we're using ctDNA to identify resistance mechanisms or guide targeted therapy. So it may not necessarily be in the gynonc space yet, but certainly for those who are using it for prostate cancer. And understanding these biologic limitations is crucial. It really helps explain where the field is headed next, towards more sensitive assays, toward multimodal approaches, and certainly towards strategies that combine ctDNA with other biomarkers and surveillance strategies to improve clinical performance. And lastly, some technical limitations and some data gaps that I came just during my research on this topic. I would say one of the biggest technical challenges is sensitivity. And in many MRD settings, we're attempting to detect only few tumor-derived DNA fragments among thousands or millions of normal cell-free DNA fragments. And performance can vary substantially depending on assay design, certainly sequencing depth, and whether the assay is tumor-informed and certainly tumor-agnostic. I would also argue another challenge right now is the lack of assay standardization across platforms, right? So different assays, different technologies use different sequencing approaches, different variant calling algorithms, and different thresholds for positivity that are not standardized across technologies. And as a result, ones from one platform certainly should not be comparable to another. And so this will make interpretation of the literature challenging as multiple sites are using different technologies, and will complicate efforts to establish a universal clinical guideline. And then last is just cost and turnaround time. Practical implementation always remains a challenge for new technology. Tumor-informed assays often require tissue sequencing, followed by custom assay development, which then increase both cost and turnaround time. And these factors also may limit accessibility and can be particularly important when rapid treatment decisions are needed. And lastly, some data gaps. There's limited prospective trials right now in gynonc. That's obviously something we're trying to combat right now. There's no standardized protocols for how to implement it into our day-to-day surveillance. And there's unknown sort of like global survival impact. And sort of piggybacking on the standardization, there's optimal testing time is really unclear. ctDNA, the future of it really depends on kind of overcoming biologic barriers, but also really solving these technical challenges as well and data gaps to make the data or make the information, just say, translatable across multiple platforms and across multiple institutions. And lastly, just some clinical pitfalls, things that I have encountered in my day-to-day practice. Perhaps the most important question is what to do when the ctDNA is positive, but the imaging is negative. We increasingly have this ability to detect months before, as I mentioned with my ovarian cancer patient. But the challenge is that we don't know whether initiating treatment, like should I have initiated treatment when her ctDNA went from 1 to 70, or should I have waited until we had radiographic evidence? We don't know whether implementing treatment at earlier time points improves patient outcomes at all. And as clinicians, we're certainly uncomfortable ignoring a positive test result, right? But we're equally cautious, I would say, about treating a disease that we can't localize or measure. And one of the central questions certainly can be useful is for prospective trial analysis to these questions. Another sort of clinical pitfall is anxiety, patient anxiety. Imagine telling a patient that we may have evidence of her cancer recurrence, but we actually can't see it. And we are not yet recommending treatment. And that uncertainty can be psychologically difficult, I would say, for patients and their loved ones. And as ctDNA becomes more widely available, I think we need to think carefully about how results are communicated and then certainly incorporated into care. And then lastly, another concern is over-testing. With highly sensitive tools, there's always a temptation to monitor more frequently, simply just, I think, because we can. However, increased testing may not necessarily translate to improved outcomes, as discussed before, and more testing can generate ambiguous results, additional imaging, invasive procedures like biopsies, and increased healthcare utilization. So as with any biomarker, the gold standard should be to answer a clinically meaningful question rather than simply generate more data. And as I mentioned, cost and access always are major barriers for emerging technologies. Availability can vary significantly by institution, geography, healthcare system. There's a real risk to access when there's disparities involved in cancer care. And so these aren't just, technical or economic issues. These are really like patient issues, right? A biomarker only creates value if it ultimately helps patients live longer, live better, or avoid unnecessary treatment. And so, I'm so sorry. In general, I would say the greatest challenge that we face now with ctDNA actually no longer is detection, but it's really how to determine when and how we act on the information. And so until prospective studies really demonstrate improved outcomes, we all need to be very thoughtful about balancing earlier detection with risks of overtreatment, anxiety, and increased healthcare costs. So as we look ahead, the question is, how we use this information to improve patient outcomes. So a few strategies that I thought of is certainly one of the most important is molecular residual disease guided therapy. So we've already seen proof of concept in colorectal cancer, such as the dynamic, and certainly what I've utilized with my patient with endometrial cancer, right, with a negative MRD after a curative intent. So the next step in gynecologic oncology is to determine then really can ctDNA identify those who would benefit from treatment escalation, de-escalation, or maintenance therapy, and that would have to be integrated into clinical trial decision making. Another major focus certainly is earlier recurrence, as we mentioned before, and earlier implementing integration thoroughly into the clinical trial space. Lastly, combination with imaging and AI is sort of interesting to corroborate with our data scientists, right? As data sets become larger, and machine learning may actually help identify recurrence patterns and can certainly integrate ctDNA with imaging, pathology, and clinical variables. And so really one of the greatest values may ultimately come from combining ctDNA data with other sources of information rather than viewing it as a standalone test. So key takeaways here are really ctDNA is a promising evolving biomarker. Their strongest data outside of gynecologic oncology, but high potential within gynecologic oncology. This requires certainly prospective validation, but the future really lies in ctDNA guided treatment decisions and really investigating these questions thoroughly to ultimately impact patient care. I would say the future of ctDNA is not simply detecting cancer earlier. The future is using molecular information to help make better decisions, right? So to identify the right patient for the right treatment at the right time. And as gynecologic oncologists, I would say ultimately that's the goal we're all working towards. I included some knowledge check questions. I'll just leave them on the screen for a moment for you to peruse and quiz yourself. The answer is coming. Great. And then 2 more. Great. Thank you so much for joining. Please feel free to reach out to me with any questions or ideas. I'm always looking for collaboration. Thank you so much.